Assalamu alaikum everyone. Hope you're all doing well, inshallah. My name is Shahd Alheijani. I'm a fifth year medical student, and inshallah today we will be covering all of MSI pharmacology. Now, the slides are going to seem like a lot, but this is only because I try to include everything to make it to make the slides inclusive. But we'll be going over the most important stuff for your exam, inshallah. So I recommend if you have the slides to open them with me because if you want to go over the extra notes in the notes section, feel free to do so. Because inshallah, I'll be explaining all the important stuff. And let's get started then. Bismillah. So those are all the lectures we'll be covering today, starting with osteoporosis up to acne, psoriasis, and pruritus. First of all, we have osteoporosis. So in osteoporosis, we have weak and brittle bones that are more prone to fracture. So we need drugs in order to make the bones stronger, in order to prevent all those complications that can happen later on. So what kind of drugs do we have? We have three main classifications. We have anti-resorptive drugs, anabolic, and supplements. Anti-resorptive will decrease the breakdown of the bone, or slow the breakdown, and under those we have bisphosphonates, estrogen, and so on. Anabolic will enhance the bone building in order to make it stronger. So both have the same effect in the end, or same end target, but with different modes of action. Finally, supplements like vitamins and minerals, including calcium and vitamin D. We'll be starting with the anti-resorptive with the bisphosphonates, which are the most important drugs we have and the main treatment for osteoporosis. So, under bisphosphonates, we have non-nitrogenous and nitrogenous bisphosphonates. Non-nitrogenous is the tilodronate. Nitrogenous includes alendronate, risedronate, ibandronate, and zoledronate. So anything ronate is a bisphosphonate usually. Now, both of them, as we said, bisphosphonates, but different mechanisms of action. So bisphosphonates will be taken up by the osteoclasts. Osteoclasts are the cells that break down the bone in order to increase the calcium in the blood. So both are going to be taken up by osteoclasts. And then we have different mechanisms. We have non-nitrogenous, which will be incorporated into ATP. They will start collecting and building up in the cell, and this will cause the cell to die. So it's cytotoxic to the osteoclasts. Meanwhile, we have the nitrogenous bisphosphonates. So this has a different pathway. This is the pathway we care about in the HMG-CoA reductase or HMG-CoA pathway in cholesterol synthesis, basically. So it will inhibit farnesyl pyrophosphate synthetase, FPPS, and this will inhibit protein prenylation, which is a post-translational modification. So after the protein is made, translated, and everything, we will prenylate that protein. And basically, this is post-translational modification, which will affect the lipid, the protein. And this will impact cell signaling. So all you have to know is it will inhibit prenylation, which is a post-translational modification. So now the osteoclasts cannot undergo cell signaling and everything. So the osteoclasts will die. So both are killing the osteoclasts, different pathways though. Now, what are the differences between them? So we said this is the main mechanism of action of bisphosphonates. Now, some of them are taken orally and others IV. So alendronate and risedronate are taken orally once daily or weekly, ibandronate once monthly. IV is zoledronate. So remember, the IV bisphosphonate is zoledronate. We can also have ibandronate, but zoledronate is the IV one. And when do people take it? If they can tolerate oral intake. So they are rapidly cleared from plasma, and sorry, just let me move this. Okay, yeah, and they should be taken 30 to 60 minutes before breakfast with plenty of water. Why is that? We will see the adverse effects in the next slide. So, first of all, the clinical use. So, when do we use it? Mainly osteoporosis, as we said. So, this is the appearance of the healthy bone. And osteoporosis, this is the weak, fragile bone. So, bisphosphonates will have decreased osteoclast activity. So, now we are increasing the buildup of bone compared to the breakdown of bone. So, this will help make stronger bones. We also use it in hypercalcemia, for example, in malignancy. So, tumor cells would release something called PTH-related peptide, which will stimulate the resorption and to increase the calcium in the blood and break down the bone. So in that case, we can use bisphosphonates, which will decrease this process in order to control the calcium levels in the blood, and at the same time, they are helping build the bones instead of breaking them. We also have in Paget disease of the bone. In Paget disease, this is a different topic. I think you guys took it already. But anyways, this is the appearance of bone in Paget disease. So you have like a disorganized buildup of bone. So you have osteoclast activity, osteoblast activity, but everything is disorganized. So bisphosphonates are also used in Paget disease of the bone. Metastatic bone disease, as we said, in tumors, osteogenesis imperfecta. Now, for the adverse effects, we have minor adverse effects, including diarrhea, abdominal pain, normal stuff. But we have some major adverse effects that we need to be aware of. So, first of all, we have esophagitis and esophageal ulcers, which are mainly with the oral medication. So, the patient must remain upright for 30 to 60 minutes. So, whenever they are taken, you can see this is the ulceration in the esophagus. And this is necrosis of the jaw. But here, this is the ulceration that happens whenever the patient takes bisphosphonates orally. So they have to remain upright for 30 to 60 minutes because if they're lying down, the medication will stay in the throat and it will cause ulceration. And this is also why the patient should take water and they're also fasting, as we mentioned. Jaw osteonecrosis is the most important side effect that will come up almost in every exam. So it's mainly with high dose chronic IV, so not with a few like pills of bisphosphonates and خلاص يعني we have jaw osteoporosis. No, this is with more chronic treatment and high dose and so on. So why is this one vulnerable? Because this is the exposed bones. And those bones are continuously regenerating due to trauma. So now you're giving bisphosphonates, you're increasing the risk of jaw osteonecrosis. Very important, very high yield, remember that. When is it contraindicated? Bisphosphonates are contraindicated in esophageal abnormalities, strictures, and achalasia because this will obviously affect the passing of the bisphosphonates, increase the risk of ulcers, which is already high enough, as we mentioned. If the patient is unable to stand upright for at least 30 minutes, again, as we mentioned, because the drug should be taken empty stomach, 30 minutes upright to decrease the risk of ulceration, then hypocalcemia because this will the main mechanism of action of bisphosphonates is to decrease the resorption. So osteoclasts usually when they break down the bones, they increase the calcium levels in the blood. So if the patient has hypocalcemia, you're inhibiting this process. You're also risking further hypocalcemia. Sorry. So they're also given with calcium supplements. Now we finished the first anti-resorptive drug. Next is estrogen. Estrogen is a hormone, so it's really helpful in postmenopausal women, and it has several benefits. So it decreases the menopausal symptoms, which are the hot flashes, the memory loss, low energy, genitourinary structure and function. So you have the vaginal atrophy and the bleeding, increased risk of UTIs. All those happen in postmenopausal women. So if you give estrogen, which is hormonal replacement, you're helping decrease those symptoms. Estrogen also has activity on the bone. So when you give estrogen, it will increase the bone density of the hip and spine, decrease bone loss. So usually postmenopausal women are at a higher risk of fractures. For example, a classic scenario would be an 80-year-old woman with a hip fracture when she, for example, fell down. So this is usually due to osteoporosis because of low estrogen levels because she's postmenopausal. So if you give estrogen, this will increase the bone density and there's a 50% reduction in risk of hip fracture. However, estrogen is a hormone, so it has some very important side effects we will try to avoid. So it increases the risk of breast cancer, cardiac conditions, stroke, and venous thromboembolism. And if it's unopposed for more than 6 months, there's a 10 times higher risk of endometrial cancer. Why? Because usually the uterus is whenever we have estrogen, it will stimulate the uterus to proliferate. So it will increase the thickness of the lining of the uterus. And then we have the progesterone, which will stabilize it, which will maintain it. And then when it decreases, there's shedding of the endometrial lining, which is the normal menstrual cycle. Postmenopausal women do not have that. And also when you keep giving estrogen, estrogen we said will stimulate the lining, so it will keep thickening and thickening and thickening. Unopposed, you do not have progesterone to stabilize it, and then reduction in hormones, so they will be shedding. Unopposed, it will keep proliferating and increases the risk of endometrial cancer. How can we minimize this risk? We minimize it by adding progestin for 10 to 14 days a month. So this will oppose the estrogen, help maintaining balance in the body, and this will decrease the risk of endometrial cancer. If the patient had a hysterectomy, obviously, no uterus, so less risk of endometrial cancer, obviously. Now we have SERMs, selective estrogen receptor modulators, raloxifene. So estrogen receptor modulators, so they will bind to estrogen receptors. It binds to estrogen receptors, and then it will affect the expression of genes regulated by estrogen. So this affects gene expression. And it maintains the bone mass by inducing a TGF-beta gene, which is anti-osteoclastic. All you have to know is it binds to receptors, anti-osteoclastic, because as we said, this is an anti-resorptive, not an anabolic, anti-resorptive. But very important thing we have in raloxifene. Raloxifene has antagonist activity at the breast and the uterus, and has agonist activity at the bone. So in the bone, it's an agonist, so it binds to a receptor, but does it inhibit or continue the action? In bones, it is an agonist, so it will bind to the receptors and reduce the number and activity of osteoclasts to increase the bone mineral density. It also decreases total and LDL cholesterol, which is a bonus. So we have, but now we care about the bone. It's an agonist on the bone, decreases osteoclast activity, and increases the bone density and strength. On the breast and the uterus, it's an antagonist. So there is no increased risk of cancer, mucosal thickness, or pain. However, in tamoxifen, it will stimulate the uterus. You have an increased risk of endometrial cancer. SERMs are usually used in breast cancer, by the way, so they will help with breast cancer treatments, but they have some side effects. For tamoxifen, the main thing, or the thing we're most afraid of, is endometrial cancer. However, in raloxifene, as you can see here, the mnemonic is relax. So you can relax when you give it. So there is no increased risk of endometrial cancer because it's an antagonist here, but agonist at the bone. But it still has adverse effects. So main adverse effect is increased risk of thromboembolic events. So increased risk of thrombus formation, stroke, and so on, especially if the patient is a smoker. It also has some effects, which are the hot flashes and the cramps, because it binds to hormone receptors. So obviously, we're going to have those hormonal side effects, like hot flashes. And yeah, that's it for raloxifene, which is a serum. Calcitonin. Calcitonin is second here. It's a subcutaneous or IM injection, which is prepared from salmon. Anyways, it acts on receptors to inhibit resorption to decrease calcium phosphate loss. What exactly is happening here? Usually in the blood, when you have too much calcium or high calcium, it binds to the C cells of the thyroid, and this when those C cells are sensing we have too much calcium now, what will we do? Releasing calcitonin. When we release calcitonin, this will inhibit osteoclasts, inhibit bone resorption. So now we are stopping the release of further calcium in the blood. So it's usually this is how it's usually regulated. When you have too much calcium, calcitonin inhibits osteoclasts. Now we have less calcium being released. So basically, what we're caring about here in osteoporosis is that it inhibits osteoclasts, inhibits bone resorption. So now we have stronger bones. And it opposes the action of PTH because in PTH, parathyroid hormone, we have the opposite. In PTH, what is happening is we want to increase the serum calcium. We're increasing bone resorption, releasing calcium, and we also it's also a phosphate trashing hormone. So we're decreasing phosphate, increasing calcium. Calcitonin opposes PTH action. Calcitonin tones down serum calcium and keeps it in the bones. تمام؟ denosumab. Denosumab, important. MAB means monoclonal antibody. So denosumab is the first monoclonal antibody we're going to talk about today. We have so many in the different lectures, but for this lecture, remember denosumab. It is analogous to osteoprotegerin, and it's a decoy receptor. Very important. It's a decoy receptor. It's a fake receptor, basically. It's also a subcutaneous injection, and its target is rank ligand. What exactly is happening here? Now, usually we have osteoblasts releasing those rank ligands, and the rank receptors are found here on the osteoclasts. So whenever rank binds to the rank ligand, it will basically stimulates the osteoclast maturation. Now, osteoclasts will resorb the bone. However, now we have denosumab, which is a fake decoy receptor. So it will bind to the rank ligand. So the target here is rank ligand. It will bind to rank ligand, inhibited from binding to rank. Now, the osteoclast formation is inhibited, and the function and survival is inhibited. And it's analogous, so it's similar to the action of osteoprotective. So denosumab helps make dense bones again by inhibiting osteoclasts. So it's anti-resorptive. It has many adverse effects. We have joint and muscle pain, infection risk, hypocalcemia, hypersensitivity, and also joint necrosis, osteonecrosis. And when it's discontinued, there was rebound increase in bone turnover. Sorry for the typo here, it's bone turnover. And when is denosumab contraindicated? In hypocalcemia again. So we need to have sufficient calcium and vitamin D before starting. Now this is just a diagram showing you the different action in different places. Here we have the fake receptors, decoy receptors, antibodies, which are denosumab. Here we have the bisphosphonates taken up by the osteoclasts, and we have estrogens acting on the estrogen and serums acting on the osteoblasts. We have something called teriparatite. This is our next section. Anabolic, which enhance bone building. So we finished with whatever inhibits the bone resorption by inhibiting osteoclasts. Now we have the stuff which are helping with bone building. First of all, we have teriparatide, which is I'm sorry. Okay. Anyways, yeah. So it's a once daily injection in the thigh or abdomen. So it's a recombinant PTH analog. It increases osteoblastic activity when administered in a pulsatile fashion. Used in osteoporosis, increase bone growth. Okay, what exactly is happening here? So teriparatide is acting on the osteoblast. It stimulates the osteoblast to increase the bone formation. It's a PTH analog, so a recombinant PTH analog. So it acts like PTH. However, didn't we just say PTH acts to increase calcium and increase bone resorption? What exactly is happening? Keyword is pulsatile fashion. So usually PTH increases bone resorption to increase the calcium levels. So chronically, in the long run, it will decrease the bone stores because we're trying to increase the calcium in the blood. However, if we give intermittent exposure, so pulsatile fashion, not continuous infusion, it will stimulate the osteoblasts more than it stimulates the osteoclasts. So when it stimulates the osteoblasts more, we're helping more bone formation instead of bone resorption. So you need to give it in once daily, low dose and intermittent teriparatide to increase the bone density and bone formation. It has some adverse effects, including dizziness, tachycardia, hypercalcemia, and muscle spasms. Now, the way I remember teriparatide is anabolic, is Terry from Brooklyn Nine-Nine. So Terry Paradise, he takes anabolic steroids, hence the muscles, and this is anabolic, increases bone formation instead of decreasing resorption, and he also gets dizzy and he has muscle spasms and all those adverse effects. So this will remind me that this is anabolic and not for resorption. Romosozumab. Again, we have another MAP, monoclonal antibody. However, this monoclonal antibody is against sclerostin. Sclerostin is usually produced by osteocytes. And when we inhibit sclerostin, what is happening? We have increased bone formation because this will stimulate the osteoblasts and decrease, so there will be less action of osteoclasts compared to the osteoblasts. So, romosozumab against sclerostin. The way I remember this is, so I won't confuse all the maps we have here. So here we have romosozumab. So my friend Rama likes to have clear skin, so sclerostin. Okay, romosozumab against sclerostin. This will increase bone formation. However, we have some adverse effects: arthralgia, headache, hypersensitivity, injection site reaction. Again, my friend Rama has hypersensitive skin. This is how I remember it. Tamam? Now, we're done with the first lecture, alhamdulillah. I hope I wasn't too fast, but feel free to go back to the slides and review some sections. And obviously, you have my contact information if you need anything, but we have two questions, quick questions to test our knowledge. A patient with osteoporosis is prescribed a medication by a physician that is administered IV on a yearly basis. What is the most likely drug prescribed for this patient? Feel free to pause and then answer with me. So, we said from those drugs, the one that's given IV yearly is zoledronate, which is a non-nitrogenous bisphosphonate. Others, alendronate, and those are oral. Zoledronate is the IV one. Now, next question. We have a 70-year-old woman with postmenopausal osteoporosis prescribed ibandronate to reduce her risk of fractures. What is the primary mechanism of action of this medication? So, answer here is inhibits prenylation or post-translation lipid modification, as we said. Let's go back to the slide and look at it here. So it's ibandronate is nitrogenous, so it blocks FPPS in the HMG-CoA pathway. It inhibits prenylation, which is a post-translational modification. Tamam? So inshallah, this first lecture is clear. Now we can move on to bone infections. Second lecture by Dr. Santosh, I believe. Now, this lecture had so many tables and so many information all over the place. We'll be going over the most important stuff. Inshallah, it will be easier. Starting off with the general overview of osteomyelitis. In this lecture, we're covering osteomyelitis and septic arthritis. Osteomyelitis is bone inflammation due to infection. So the bone itself is inflamed. In septic arthritis, arthritis means joint. So osteomyelitis, the bone itself is affected. Septic arthritis, the joint, for example, the knee joint mainly. So what is the source? It can be endogenous or exogenous. Endogenous, it can be a hematogenous seeding or bacteremia. And in that case, the most common cause is S. aureus, Staph aureus. Or it can be a TB infection in the vertebra. So this is Pott's disease. So if the vertebrae are affected, usually it's a TB infection. But obviously there will be clues in the question. So it will be in vertebra. The patient will be in, for example, in homeless or in a very high risk setting, and they have all those fever, night sweats, all those typical signs. And this is also another picture showing you what is happening in osteoporosis. So basically, it starts with an acute inflammation, and then it progresses to chronic inflammation that may cause sinus formation, pus, everything. So first off, we have the endogenous. Exogenous, it can either be by direct spread from a contiguous focus. For example, if the patient had a fracture or surgery, now they are more prone to infection by Staph aureus or epidermidis. If they have skin or vascular insufficiency, when does this usually happen? Main example you're gonna get or question you're gonna get is diabetic foot. Diabetic patients, they have an ulcer, for example, an ulcer in their foot, and now they can't feel anything, and now suddenly they have fever, they have an infection, they have pus drainage. This is due to exogenous osteomyelitis from a contiguous focus, and it's usually polymicrobial. So diabetic foot, they will have polymicrobial infection or pressure ulcer. And GU, genitourinary, by gram-negative rods and Enterococcus. It can also be exogenous by direct inoculation. So in surgery or in trauma, you can directly inoculate the bacteria, for example, Staph epidermidis. Now, important notes mentioned in the lecture. Staph aureus is the most common cause in adults and IV drug users. Most common cause of osteomyelitis, usually Staph aureus. Special cases, you have different causes. So in newborns, there is higher risk of E. coli and group B strep osteomyelitis. In children, again, we have Staph aureus and group A strep, which is pyogens. UTI nosocomial. You need to remember that we have an increased risk of Pseudomonas aeruginosa. Sickle cell. Now, this is very important to remember that in sickle cell patients, the most common cause is still Staph aureus, but they are more susceptible to Salmonella osteomyelitis or Salmonella infection. But the most common cause is still Staph aureus. However, compared to healthy people, they have more rates of Salmonella infection. Now, in orthopedic devices, you have higher risk of coagulase negative staph, which is Staph epidermidis, because this is a new device inserted into the body, so it can cause infection by Staph epidermidis. And what is the general empiric treatment for osteomyelitis? General treatment, because the most common cause is going to be Staph aureus, but there is higher risk of, for example, Pseudomonas and gram-negative infections or agents. So empiric treatment is vancomycin for staph aureus, especially MRSA, methicillin-resistant staph, and gram-negative. Against gram-negative, we have ceftriaxone. So the main empiric treatment is vanco and ceftriaxone. However, we look into specifics. Now, in main treatment, you have to admit the patient, give them IV antibiotics because this is a very serious infection and it can lead to very bad complications. So you need to consult infectious disease, surgery, pain management, you know the drill. If there is pus, we need to remove it first. So antibiotics are not gonna go through the pus. So if there is pus, you need to debride the wound. You need to remove this pus to restore the periosteum and blood flow, and then you can give the antibiotics, and they can actually reach the site of infection. And antibiotics are effective before pus formation, and they also prevent the pus formation, and they should be continued after surgery. So as we know, we need to continue the course of antibiotics. We can't just stop it. Now, if the patient is clinically stable, you can hold antibiotics until a bone biopsy is obtained, but usually we give empiric treatment. How long do we give this treatment for? It depends. For acute infection, you can give it for 4 to 8 weeks, in chronic, 3 to 12 months, and vertebral for 6 weeks. Vertebral, as we said, Pott's disease, TB. Um, so, when do we do surgery for treatment? If we have acute osteomyelitis, but the drugs didn't work, we tried medication, they didn't work. We have chronic osteomyelitis, which is for 3 to 12 months. For a long period of time, chronic osteomyelitis. So now we have to do surgery. If there is complications of pyogenic vertebral osteomyelitis, so for example, if this osteomyelitis in the vertebra, it caused severe complications. For example, now it's pressing on the spinal cord, it's causing instability, and now the patient has neurologic symptoms like numbness or decreased movement in their legs, bladder incontinence, all those side effects that can happen due to spinal cord compression or even infiltration. And if you have an infected prosthetic device, if you have an infected prosthetic and you give medication, you're not really treating the main cause. So you need to remove this prosthetic and replace it. Now, those are the main treatments we use for the different microorganisms. Now, for MSSA, which is the normal staph, which is not methicillin resistant, it's sensitive. Usually, nafcillin, oxacillin would be good. Alternative would be ceftriaxone. However, if you're suspecting methicillin resistant, you need to give vancomycin. If vancomycin is not available, you can give linezolid, okay, or daptomycin. So usually in septic arthritis, they don't risk it and they just go with vancomycin. Or vancomycin can be given empirically, as we mentioned earlier. Coagulase negative staph, we have vanco, and then we have all of those. You can read them at your own time. Important thing is P. aeruginosa. Most important, or usually what they go with, is cefepime, which is a fourth generation cephalosporin, or meropenem. An alternative would be a fluoroquinolone, which is ciprofloxacin, or also ceftazidime. Candida, antifungal, amphotericin, followed by fluconazole. Now, for the treatment, uh, we can attack this bacteria from different aspects, either by antimetabolites, which affect folic acid synthesis, cell synthesis inhibitors, which include all those medications we know, the penicillins, cephalosporins. We have protein synthesis inhibitors like the macrolides, tetracyclines, aminoglycosides, all those, and nucleic acid synthesis inhibitors, mainly fluoroquinolones. So, to be listed. So in your lecture, the doctor skipped over most of those slides, but let's cover the most important things on those slides. Starting off with penicillin, cell wall synthesis inhibitor, we have different types. Natural penicillinase resistant, penicillinase sensitive amine penicillins, and penicillinase sensitive anti-pseudomonas. So the natural includes penicillin G, which is susceptible to beta-lactamase. So we also have flucloxacillin, decloxacillin, which are used for penicillinase-resistant staph, but not MRSA, which is why here we said if you're suspecting MRSA, you give vancomycin, not nafcillin, oxacillin, and all those things. Okay, so just remember that those drugs are not used for MRSA. And piperacillin is used for P. aeruginosa. So sometimes if you give piptazo, so piperacillin and tazobactam, this is also used against P. aeruginosa. So this is penicillin that works for P. aeruginosa. And you can also give it with the beta-lactamase inhibitors to protect the antibiotic from destruction by beta-lactamase. So, for example, amoxicillin with clavulanic acid, peptazo, so piperacillin with tazobactam, so ampicillin, sulbactam, and so on. Cephalosporins, we have first to fifth generation. Now they have different coverage, but the most important things you need to remember is that third generation, ceftazidime, covers Pseudomonas aeruginosa, and fourth generation, cefepime, also covers Pseudomonas aeruginosa. Ceftaroline, which is fifth generation, it covers MRSA and has no activity against Pseudomonas. So it does cover MRSA, but not Pseudomonas. Those are the main things you need to remember. Vancomycin. Vancomycin also cell wall synthesis inhibitor, but it inhibits bacterial cell wall synthesis in a step earlier than beta lactamase. So beta lactams, I mean. So here beta lactams are inhibiting PBP, which is penicillin binding protein. Vancomycin is gonna attack the cell wall synthesis at an earlier step here. So it binds to D-alanine, and it will block the trispeptidase, which is the step before this one. So they're both inhibiting cell wall synthesis at different steps. Usually, you don't really need to go into much details, but sometimes they can do stuff and get you such questions in SAQs, like what happened with us. Sometimes you're going to get it in third year randomly, so it's good to know right now and refresh your memory from POD. And yeah, vancomycin is not absorbed from the gut, and it's usually given as an IV infusion. So remember, vancomycin is given IV. So, for example, if a patient presents with joint infection and you're suspecting septic arthritis, you admit them to the hospital. You give them IV vancomycin and ceftriaxone and all the medication. You aspirate the joint, you do everything, but the important step is empiric IV vanco. Clindamycin. Now, clindamycin is a protein synthesis inhibitor. So it binds to a site in bacterial 50S ribosomes, and it inhibits the ribosomal translocation step of protein synthesis. So here you have the 50S subunit, which is where clindamycin actually works. And it's effective against most gram-positive, including Staph aureus. What makes it special is it's highly active against anaerobes, especially Bacteroides fragilis. So, and it also achieves high concentration in the bones. So, a good thing about clindamycin, it can attack anaerobes, which is why it's used to some like GI infections. And it achieves very high concentrations in bones, which is why we're using it here in osteomyelitis too. So it's used for anaerobic and also for mild to moderate acne. Very important side effect you need to remember. Main thing for clindamycin is it can cause C. difficile infection and pseudomonas colitis. So this is the appearance of the colon. So this is what really limits its use and limits the use of clindamycin in clinical setting, because it compared to other antibiotics, it has higher chance of causing pseudomembranous colitis. Linezolid also protein synthesis inhibitor, but it binds to the 23S subunit of the 50S and prevents the complex formation. Main thing you need to remember about linezolid, it's also active against MRSA, also VRSA, so vancomycin resistant staph, vancomycin resistant enterococci. So against MRSA, against VERSA2, and VRA. Why is it superior? Or what makes it special is that it's used orally compared to vancomycin. As we said, vanco is IV, linezolid is oral. Quinolones. Oh, by the way, just saying, this does not mean that linezolid is the first line. Vancomycin is still the first line. Quinolones. So we have first of all generation. You need to remember that second generation ciprofloxacin. It has activity against Pseudomonas, but if there is a chance the joint infection or the bone infection could be due to strep pneumo, we don't give this because it does not cover streptococcus pneumonia. So in that case, what do we give? Levofloxacin, so which is the third generation. Same for second generation, still covers Pseudomonas, but also covers strep pneumo and has expanded activity against atypical. Fourth generation, which is gemifloxacin, has broad anaerobic. So what you need to remember is ciprofloxacin, Pseudomonas, levofloxacin, Pseudomonas, and strep pneumo. And they're all still covering gram-positive, gram-negative, atypicals, all those things. But those are the key features. Now, Dr. Santosh had those two questions on the slides. I just included them here for the sake of completion. But basically here, in the first case, we had a child who hit his leg and now has typical symptoms of osteomyelitis, which is the joint pain, bone pain, tenderness, swelling, and then MRI it shows the bone is getting destroyed, which is osteomyelitis due to trauma. Main cause is Staph aureus, but we have also other causes, including coliform bacteria, Pseudomonas aeruginosa, which is typical for a trauma patient. Empiric treatment, we have nafcillin and ciprofloxacin. As we said, ciprofloxacin it can cover Pseudomonas, nafcillin can cover Staph aureus, but usually you go with vancomycin and a third generation cephalosporin. For example, ciprofloxacin and I mean ceftriaxone and all those. If Pseudomonas is isolated, we need to give two antibiotics with Pseudomonal activity. So we do aggressive treatment for the patient. But usually the empiric treatment is Vanco and ceftriaxone. Now, if a child has fever, medial leg tenderness, swelling, now has pus discharge with high white blood cells, ASR, CRP. So there is inflammation and there is pus. As we said, we need to drain the pus or the abscess or whatever is happening, and we take it for culture to isolate and see what exactly is causing this infection, and we will treat accordingly. Now, this is an extra table also in the doctor's slides. Hematogenous osteomyelitis, as we said, most common cause, Staph aureus. We still have other causes. So we can give penicillinase, resistant penicillin, and third generation cephalosporin. Alternative, as we mentioned multiple times, Vanco and third generation cephalosporin. Particularly if we're suspecting MRSA, we can't just give any penicillin. Patients with sickle cell, they have Staph aureus, Salmonella, and Pseudomonas. Main is still Staph aureus, but thus they are more prone to Salmonella species. Also, the strep pneumonia, because their spleen is not really as functional, or they can get osteosplenectomy, and now they are more susceptible to such bacteria like strep pneumo and all those encapsulated bacteria. So now we need to target those. We can give fluoroquinolones, but as we said, if we're suspecting that strep pneumo can be a cause, we give levofloxacin. And alternative is a third generation cephalosporin. Osteomyelitis due to trauma is what we just covered in the previous slide. So nafcillin and ciprofloxacin, or Vanco and third generation cephalosporin with anti-pseudomonal activity. Candida, as we said, Candida is fungus, so antifungal, amphotericin, and fluconazole. Now for septic arthritis. The causes can be bacterial, viral, mycobacterial, and fungal. So in fungal, we have Candida, coccidiomycosis, histoplasmosis. We also have a million other conditions, but we need to focus on bacterial for now. It could either be gonococcal or non-gonococcal. Gonococcal means Neisseria, and non-gonococcal are the other infections. So what when we are suspecting septic arthritis, we need to take an aspect of the joint. I'm pretty sure you guys covered this in other lectures in clinical or patho, but just brief overview. If you have septic arthritis, you need to drain the joint. You need to aspirate, and you test the synovial fluid. Synovial fluid will show elevated white blood cells, which are usually even more than 50,000. Sometimes in special cases they can be low. Most of them, 90% will be neutrophils. Gram stain will be positive, usually staph infection. Sometimes it will show the gram negative rods. The culture will be positive, and the most sensitive is a biopsy. So you take the synovial fluid and you test it. And there will be leukocytosis, elevated ESR and CRP, and positive blood cultures. And again, the most common cause is Staph aureus. Now, how do you treat the native joint with septic arthritis? Surgical drainage, as we said, you need to drain the joint. You cannot keep the fluid inside there. And then you do a gram stain and you start empiric antibiotics. You do not start the empiric antibiotics and then you drain the joint, because now you can't really test and see what bacteria are causing it. So you drain the joint, you give antibiotics. Now, what if the gram stain is negative? You can't really tell what is in there. You need to give empiric treatment with vancomycin. Again, most common cause is Staph aureus, and we don't want to risk it. We're giving empiric vancomycin. If we're suspecting gonococcal, which is Neisseria gonorrhea, if we're suspecting gonococcal arthritis, you add ceftriaxone. Ceftriaxone is third generation cephalosporin. You need to give this for gonococcal arthritis. So sometimes patients with Gonorrhea, they can present with arthritis, tenosynovitis, rash, different manifestations. It's strictly only an STI. It is an STI, but I mean not only in the genital tract. It can also spread to other locations. So when you suspect gonococcal arthritis, we add ceftriaxone. If the patient is an IV drug user or immunocompromised, we also add anti-pseudomonal. How long do you give the antibiotics? You give IV antibiotics for 2+ weeks, or more than 2 weeks, followed by oral antibiotics. So you start with IV and then you can switch to oral. And the antibiotics depend on the organism. Now, prosthetic joint. Now, for example, you get a patient, 50-year-old, hip replacement. Now you're suspecting the hip is inflamed. There is redness, swelling, fever, and the joint is very painful in movement, and you're suspecting septic arthritis. The risk is high in the first 2 years, and more than half is due to staph infection. Can be aureus and epidermidis, because as we said, orthopedic devices, staph epidermidis, and also staph aureus is still the highest cause. And some are also polymicrobial. It can be either early or delayed infection. So early means less than 3 months, and it's usually due to a virulent organism such as MRSA, methicillin-resistant Staph aureus, or it could be delayed. So after 3 to 24 months, and usually less virulent microorganisms such as P. acnes and the coagulase negative staph, which is Staph epidermidis. So first 3 months, usually MRSA, more than that, usually Staph epidermidis and P. acnes. Or it could be delayed, or it could be late. So after 24 months, after the whole year has passed, we have a secondary hematogenous seeding, and diagnosis requires arthrocentesis. So again, you need to drain the joint, remove the fluid, culture it, do gram staining, do all that, and then you get your organism, and you can treat accordingly. You need to give prolonged antibiotic course. Again, start with vancomycin and then third or fourth generation cephalosporin for 6 weeks. You need to replace the joint sometimes. Lifelong suppressive antibiotics. Again, consult infectious disease and orthopedics because this is, I forgot the word. Multiple teams are involved in this. تمام. Disseminated gonococcal infection. As we said, Neisseria gonorrhea is an STI that sometimes gets disseminated, it spreads around the body. It can cause arthritis, tenosynovitis, dermatological conditions, meningitis, and so on. So Neisseria gonorrhea is the most common, is the cause, and this is the most common type of infectious arthritis in sexually active young adults. So usually you're gonna get, for example, a 22-year-old. You can tell that, for example, they have sexual partners, and now they have a very inflamed joint, and now you're suspecting septic arthritis, and you can tell from the picture it's a young adult and they're sexually active. Start thinking about gonococcal infection. What do you give for gonococcal arthritis? Ceftriaxone. Ceftriaxone, 7 to 14 days. Ceftriaxone, gonococcal. And usually, when a patient gets an STI, you need to cover for other STIs because as long as you did not make sure that patient only has gonorrhea, there's a chance they were infected by more than one STI. For example, chlamydia, herpes, HIV, a million other things. So usually, whenever you want to treat gonorrhea, you also treat empirically for chlamydia co-infection. So you give empiric doxycycline for 7 days or azithromycin. So you give ceftriaxone for the gonorrhea. You also give either doxycycline or azithromycin for chlamydia until you confirm that there is no chlamydia infection. Then you can stop this and just continue with the gonorrhea medication, which is ceftriaxone. And you also need to do joint arthroscopy and lavage. Sometimes if there's purulent arthritis, so there's pus in the joint, you need to do lavage. More stuff, again, now the common microbes, gram-positive in cocci in clusters, Staph aureus epidermidis, Staph aureus mostly in normal joints, also in prosthetic and damaged joints. In prosthetics, start also thinking about the Staph epidermidis. Vanco is the main thing. Chains, strep, usually in healthy adults, but also in spelling dysfunction. As we said, strep pneumo in, for example, in sickle cell patients, because they have spelling dysfunction, more susceptible to streptococci. Penicillin G or ampicillin. Now, gram-negative, you also have a diplococci, which is Neisseria gonorrhea, and rods like E. coli, Pseudomonas, and so on. gonorrhea, and sexually active, ceftriaxone. You also have in IV drug users, GI infections, trauma, elderly. You have Pseudomonas infection and E. coli. And this is treated with cefepime, which is the fourth generation cephalosporin, or peptazo, as we said, which was the last one in the table for the penicillins. So this is the one that has anti-pseudomonal activity, given with beta-lactamase, which is tazobactam, or an anti-pseudomonal amino glycoside in IV drug users. We're done with the second lecture. Now we have two questions. Child with a known penicillin allergy requires treatment for a bacterial infection. Which of the following is an appropriate alternative? Pause. تمام. Now usually bacterial infection, what do we give? We can give penicillin, we can give cephalosporin, and so on. But our case here, the patient has a penicillin allergy. You cannot give penicillins. You cannot give anything that can have a similar reaction. So in that case, our appropriate alternative would be azithromycin. Azithromycin is a macrolide. Macrolides are a good alternative for for patients with penicillin allergy. Second case, 45-year-old male presents to the emergency department with fever, severe localized pain, swelling in his right tibia. Upon examination, tibia is erythematous and warm to the touch with little swelling. After taking thorough history, performing physical exam, proper investigation, diagnosis of acute osteomyelitis is made. What is the empiric treatment? This whole case is useless. You just need to know that the patient has acute osteomyelitis. What is the empiric treatment? You don't have anything specific like sickle cell, trauma, orthopedic device. So usually, B, vancomycin ceftriaxone would be our empiric treatment. This brings us to our third lecture for today, inshallah. This was actually third and fourth lecture. So rheumatoid arthritis was two lectures for you guys, one presentation. Inshallah, we'll make a bit something with this presentation. So, a general overview of rheumatoid arthritis. I'm not going to get into details because you guys took it probably a million times in clinical and pathology lectures. But what you need to know is usually more common females, peaks in 40 to 60 years of age, predisposing factors including genes such as HLA-DR4. So remember 4-walled room, which reminds you of rheumatoid arthritis, and anti-CCP, which is more specific than rheumatoid factor. In rheumatoid arthritis, you have prolonged morning stiffness for more than 1 hour, usually symmetric, and most common in the metacarpophalangeal and proximal interphalangeal joints and the wrist. So those are the most common areas for rheumatoid arthritis. Now, we have initiating factors, which include the genetics, which we covered just now, would also include the environment and the hormones. Those would initiate the cascade, and then this will cause immune activation, in which we have citrullination of proteins to give us this anti-CCP, and activate the T cells and the B cells. When they're activated, they start producing autoantibodies, rheumatoid factor, and all those things that cause the inflammation in the joints. Now we have the cytokine cascade because, as we said, T cells, B cells, they start producing inflammatory factors, cytokines, and this will cause the Panis formation. You covered already in other lectures. You have the matrix metalloproteinase, which are degrading the collagen, further breaking down the joints. You have rank ligand overexpression. We said rank ligand would help with osteoclast activation. Remember, we covered in the osteoporosis lecture. And we have fibroblast activation. So basically, what we're getting is the osteoclasts are functioning, they are destroying the joint. You have fibroblasts are getting activated, you have fibrosis, have Panis formation, inflammatory condition. This will cause inflammation in the joints. And over time, this will cause several severe problems for the patient. They'll have prolonged morning stiffness. They can't really move their joints, and in the long run, it will cause severe distress for the patient. So we need to manage that with medication. What the medication is gonna do is clinical remission and stop the progression usually. So we are managing the symptoms, we're stopping the progression so that the patient can have some movement or some control over their joints and their lives to decrease their distress and improving their quality of life. And we are also trying to reduce the cardiovascular mortality. But some of the drugs we have are only for symptomatic management. Only few of them are actually disease modifying, which are the DMARDs we're going to talk about in a bit. But the other drugs are only for symptomatic management. So Pharmacology of rheumatoid arthritis has those main classes. We have the NSAIDs, glucocorticoids, the synthetic DMARDs, biologic DMARDs, and the targeted synthetic DMARDs. We're going to take them one by one. But DMARDs is disease modifying anti-rheumatic drugs. So those are the disease modifying, actually disease modifying. Those are symptomatic management. NSAIDs and glucocorticoids. Starting with the NSAIDs. Now we know the NSAIDs. Ibuprofen, diclofenac, celecoxib, all those the normal drugs we have. So they will decrease the pain and inflammation and the fever, but not the disease progression. As we said, the DMARDs affect the disease itself. This is only for the symptoms. So it decreases the inflammation by inhibiting the COX enzymes. So it inhibits COX-1 and COX-2 for non-selective NSAIDs, and only COX-2 for the selective ones, such as celecoxib. So they reduce swelling, improve motility and quality of life. They're also cheap, over the counter. And you always combine them with PPI in high-risk patients, which, for example, patients age above 60, H. pylori, and steroid use, because they can have certain side effects, which we'll get to in a bit. You need to avoid them in chronic kidney disease, heart failure, and peptic ulcer disease, active peptic ulcer, because NSAIDs can cause ulceration and chronic GI bleeding. So if the patient already has ulcers, we don't want to give them NSAIDs. Also in heart failure patients and CKD, because they have effects on the kidney function. We'll also cover this in a bit. You need to monitor the blood pressure, creatinine levels, and potassium every 3 to 6 months, because this will tell you about the kidney function. Remember, the least toxic one is ibuprofen, also naproxen. Naproxen has a longer half-life. Obviously, you don't have to remember the doses. I just put them here for completion. We have the COX-2 selective one, which is celecoxib. It increases the GI risk because COX-2 is usually in inflammatory conditions, and COX-1 and COX-2 are COX-1, I mean, is the one that is always produced. So if we're selective only for the inflammatory conditions, we are decreasing the GI risk because decreased risk of peptic ulcers and all those things that are related to the COX-1. But there's a higher risk of cardiovascular conditions, for example, a higher risk of thrombosis and thrombotic attack in celecoxib, compared to the non-selective NSAIDs, diclofenac, ibuprofen, and naproxen. So when we inhibit the COX-1, COX-2 in the arachidonic acid pathway, we are decreasing the pain and inflammation due to the prostaglandin secretion. And here are the main side effects we have. So adverse effects, we have GI effects, and the risk is higher in age above 65 and the patients on steroids or anticoagulants. We also have renal and cardiovascular effects. So let's look at this. So COX-1 is usually produced in the GI mucosa, so inhibited by non-selective NSAIDs. This will decrease the mucosa protection, increasing the risk of peptic ulcers, GI bleeding due to COX-1 inhibition. In the kidney, we also have COX-1 and COX-2. So when you are inhibiting those, you are increasing the risk of kidney injury. So this will cause sodium and water retention, hypertension, and hemodynamic acute injury, which is why we said we need to monitor the blood pressure and the creatinine levels in the patients. And we also have cardiovascular effect. So when we inhibit COX-1 more than COX-2, as we said is the case in celecoxib, we are increasing the risk of stroke, thromboembolic conditions, and MI, myocardial infarction. And it has some drug interactions. So, for example, with warfarin, there's increased risk of bleeding because, as we said, it causes peptic ulcer, GI bleeding. With ACE inhibitors and ARBs, because it decreases the anti-hypertensive effect and increases renal toxicity, as we said here. So it will interact with the ACE inhibitors. And we have FDA box warning, as we said, increases the risk of stroke, MI, GI, bleeding, perforation, ulcers. So you need to use the lowest effective dose for the shortest duration. You can't keep using them for a very long time because of all those very serious side effects we have. Glucocorticoids, as we said, those two NSAIDs and glucocorticoids are mainly for symptomatic management, and glucocorticoids is also bridging therapy while awaiting DMARD effects, because DMARDs are disease modifying, so they need time to start acting, and we'll cover them in a bit. But we need something so that it will manage for now only, so it's bridging therapy until DMARDs start having their disease modifying effects. What glucocorticoids do is they decrease NF-kappa B activation, also in the same pathway. So it will decrease here. It will decrease in the cell. The glucocorticoids will bind to glucocorticoid receptors, go into the cell, into the nucleus. They will affect the genes. And what we're getting out of this is we are decreasing NF-kappa B activation, decreasing the transcription and translation of mRNA and the inflammatory cytokines. So we have less cytokines being produced. Cytokines are what are driving our inflammation. We decrease the cytokines, including IL-1, IL-6, and TNF-alpha mainly, and we decrease phospholipase A2. And by this way, we're decreasing prostaglandins and leukotrienes. So we are decreasing all those pro-inflammatory factors. So it is anti-inflammatory and immunosuppressive, and it will improve the mobility of the patients. Again, you do not use it as monotherapy as it does not affect the disease and it has severe adverse effects. And if you stop it suddenly, the patient will go into a crisis because they will have an adrenal crisis, which will have severe effects. We'll cover in a bit. So you need to taper it down. So you give if the patient has to take glucocorticoids, you do not stop it suddenly on a random Monday. Yeah, you need to taper it down until you stop it. And again, short-term use is preferred. So again, as we said, you need to taper it down within 3 months. You can use as the intra-articular injection for monoarthritis. So if it's just one joint, you can use an intra-articular injection. You give it with calcium and vitamin D for osteoporosis prevention because glucocorticoids will cause decreased bone formation and they will cause fragile bones. So you need to give with calcium and vitamin D. And for the millionth time, you need to taper slowly to avoid adrenal crisis. You need to monitor blood glucose because glucocorticoids will increase glucose levels and they will cause spiking. So you need to monitor the glucose, blood pressure. They can cause hypertension, bone marrow density because, as we said, it can cause osteoporosis. So you need to do a DEXA scan at baseline. If you know that the patient is gonna take glucocorticoids for a long time, you need to measure it as baseline so you can have a reference. So every time you measure, you are comparing it to the baseline. Is the patient having osteoporosis, increased risk of osteoporosis, fragile bones, fracture risk, and so on? And you do an eye exam because it can affect the eyes too. And you need to avoid live vaccines because we're decreasing the immune system or the immunity of the body. So you avoid live vaccines while on therapy because they're not going to be effective. And you consider pneumocystis jirovecii prophylaxis with trimethoprim, sulfamethoxazole, if you're taking prednisolone high doses for a very long time. So this will increase the patient's susceptibility to opportunistic infections, including pneumocystis infection. So you give them trimethoprim, sulfamethoxazole. Adverse effects are dependent on the dose and duration, as we said. If high dose for a long time, you're going to get such side effects. Then hypertension, immunosuppression, go crazy. So here, our mnemonic is high homie. So we have hypertension, immunosuppression, go crazy, which is mood changes, glaucoma, which is the effect on eye, which is why we have to do eye exams, growth retardation, hyperglycemia. As we said, glucocorticoids are going to increase the blood sugar level, so we need to continue monitoring. Hair growth, which is hirsutism, osteoporosis, which is why we need to do DEXA scan for the patient. Muscle weakness, it will cause muscle atrophy over a long time. So you're going to see the patient with very thin limbs, and then they're going to have more Cushingoid features. You're going to have an increased appetite, so you'll have higher weight, and there will be edema. Plus, you have avascular necrosis risk, which is basically whenever you have, for example, necrosis in the femoral head. You have Cushingoid features, as I mentioned, which are the striae, the acne, the moon face, the buffalo hump, increased central, central obesity with the thin limbs because of the muscle atrophy, and adrenal insufficiency because you're suppressing the HPA axis, which is the hypothalamus pituitary adrenal axis. So you keep giving exogenous glucocorticoids, this axis will be suppressed because you now have exogenous glucocorticoids. Now you have adrenal insufficiency, which is why if you stop glucocorticoids suddenly, this axis is suppressed. So it can't make up for that right away. So now you have adrenal crisis. The adrenal glands are not used to working because it's been just being fed glucocorticoids exogenously. So now the patient is in crisis, which is why you need to taper it down. Now we covered the first two classifications. Now we have the actual disease-modifying drugs, which are the conventional synthetic DMARDs, which is mainly methotrexate, which is the main thing we usually use for rheumatoid arthritis, main safe treatment. The flunomide, sulfasalazine, and hydroxychloroquine. We have the biologic, which are TNF inhibitors or non-TNF, and the targeted synthetic, which are the JAK inhibitors. You need to give them for 2 to 6 weeks time for clinically evident effects, and most are contraindicated in pregnancy. You only have sulfasalazine, mainly that is safe in pregnancy. Others are usually contraindicated, and you need to give them time, as we mentioned, because they're disease modifying. You need to give them time to have their effect. So if the patient is in methotrexate, they come to your clinic in a week and they're like, "Yeah, your drug did not do anything to me. You did not help me." Tell them that they need some time in order to take the effect. They can take bridging therapy with glucocorticoids for now, and then give them some weeks, and then they will start acting. Methotrexate is the anchor DMARD. Just a second. Methotrexate is the anchor DMARD, the main thing we use. Its main effect, it has two main effects. It's a folate antagonist, so it inhibits dihydrofolate reductase, so it decreases the levels of tetrahydrofolate. Now, at low doses, this will decrease the purine and pyrimidine synthesis and decrease TMB cell proliferation. All you have to remember is it inhibits dihydrofolate reductase, decreases tetrahydrofolate, which gives it its anti-inflammatory effect, and it also blocks the ICAR transferase. I think I forgot the exact what exactly ATIC stands for, but it inhibits this enzyme, the ATIC enzyme. Now, this will block the conversion of ICAR to its metabolite. So now, when ICAR reaction is inhibited, this will start building up. ICAR starts accumulating in the cells, and this will increase the extracellular adenosine, which is anti-inflammatory. Now, ICAR is increasing in the cell. As you can see here, adenosine release is increased, and then adenosine will start binding to receptors, inhibiting the NF-kappa B activity. As we said, NF-kappa B, we need it for the release of cytokines and all those inflammatory mediators. So if we inhibit NF-kappa B activity due to adenosine buildup, we are decreasing the neutrophil adhesion, cytokine release, mainly IL-1, IL-6, the NF-alpha. تمام? Now, oral bioavailability is high, but if you increase the dose, the oral bioavailability will decrease. So we give it subcutaneous or IM. Information you can ignore for now. And it's metabolized by hepatic polyglutamation, which basically you're adding polyglutamine to the methotrexate itself in the liver cells, in the hepatocytes, and it's eliminated by mostly 80 to 90% by the kidneys, which is why we need to make sure the kidney function and the liver function are good before starting methotrexate, because it's metabolized by the liver. So if the patient has liver disease, you need to be aware about methotrexate, and it's also eliminated by the kidneys. So now, if methotrexate inhibits dihydrofolate reductase, now this will affect thymidine synthesis, DTP, and TTP, which will affect DNA synthesis. Now, this can have effects on the human cells too, which we need to avoid. So now, how are we gonna rescue the cells? Because we are affecting DNA synthesis, which is kind of important, I guess. So you need to give leucovorin rescue. Leucovorin will act here, so it restores active folate stores in the host cells. So now we are giving leucovorin, which is folinic acid. Now this will act as rescue in methotrexate in patients who take methotrexate. So always, whenever you give methotrexate, remember you need to give folinic acid or leucovorin with it. Now, again, NSAIDs will increase toxicity because they decrease clearance by the kidneys, and you need to monitor CBC, CMP, which is a metabolic panel, LFTs, liver function, because we need to make sure the liver is functional whenever we want to give methotrexate. Pregnancy test. Methotrexate The methotrexate will severely affect the fetus, and it's actually even used in ectopic pregnancies to terminate the pregnancy. So imagine if the patient is pregnant and she's taking methotrexate. This is literally used in ectopic pregnancy. So you need to make sure the patient is not pregnant when you give methotrexate. So you need to do a pregnancy test. And yeah, we discussed all of this. Now, adverse effects. It has GI adverse effects. So you get nausea and stomatitis. Hepatotoxicity. It can have severe effects on the liver. So you need to monitor the liver function because if you keep monitoring and now you are realizing that the patient AST and ALT levels are starting to increase, now you're thinking that maybe methotrexate is affecting the patient's liver. So we need to do something about this. You can't just continue the therapy forever. And there's cirrhosis risk, especially if the patient is taking alcohol and if methotrexate is used for a long term. Myelosuppression, like leukopenia, thrombocytopenia, and pulmonary effects. So it causes pneumonitis. It can affect the lungs. So here we have this mnemonic, which is metho, mucosal damage. So it can cause GI upset, MSS, nausea and vomiting, thrombocytopenia, which is myelosuppression, leukopenia, thrombocytopenia, which increases the risk of infections and fever. Hepatotoxicity. Make sure you measure liver enzymes whenever you give methotrexate. And fibrosis of the lung. So it can cause pneumonitis and even fibrosis at further stages. Contraindicated in pregnancy. It is teratogenic. Category X. Absolutely unacceptable in pregnancy. So you need to make sure the patient is not pregnant. Contraindicated in pregnancy. And a very low EGFR, which is a marker of decreased kidney function. Alcoholism, liver disease, as we said, and in severe cytopenias because it can cause myelosuppression. And if you have severe cytopenias, in which, for example, if you have absolute neutrophil count below 1,500, contraindicated. So methotrexate, as we said, folic acid analog, competitively inhibits dihydrofolate reductase, used here in rheumatoid arthritis, psoriasis, also in leukemias, lymphomas, and it causes myelosuppression. Myelosuppression is reversible with leucovorin. So myelosuppression means we are suppressing the cells. Why? Because we're inhibiting DNA synthesis. We don't want to inhibit all those cells, the leukocytes, the platelets, and all those cells. We just want to inhibit the cells that are causing the inflammation. So this is reversible with the leucovorin therapy we mentioned. Have hepatotoxicity, mucositis, as we mentioned. Now we have an alternative DMARD, which is leflunomide, which is not superior to methotrexate. Methotrexate is still superior, but this is an alternative we have. It is a prodrug and it's converted to an active metabolite in the body. Its action, it inhibits dihydroorotate dehydrogenase, DHODH. So this is its action. Remember those screenshots I include are from first aid. And to me, they're really helpful because they really solidify the concepts in your head. All those screenshots, those small summaries, all those diagrams, and whenever you're doing the exam, you start thinking about those diagrams easier than thinking about all the text that is in between. So try to remember them. You don't obviously need to memorize all of this. Just remember that pyrimidine base production. Here is where we have leflunomide action. It inhibits in the orotic acid pathway, inhibits dihydroorotate dehydrogenase. Decreases the UMP formation, decreases pyrimidine production, which will affect DNA and RNA synthesis. This will decrease T cell proliferation. T cells are used, will activate the B cells, and then B cells will produce antibodies. So if you decrease T cell proliferation, you decrease autoantibody production, which is what is basically happening in rheumatoid arthritis. So it reversibly inhibits dihydroorotate dehydrogenase, preventing pyrimidine synthesis, suppresses T cell proliferation. T cells will activate the B cells, which will produce the antibodies. We are inhibiting all of this. Used in rheumatoid arthritis and psoriatic arthritis. Side effects include diarrhea, hypertension, hepatotoxicity, and teratogenicity. Let's cover this. So you need to wash out before pregnancy with cholestyramine. So again, you give the patient cholestyramine, you wash out the leflunomide. Why? Because it has a very long half-life. It persists for months in the body. So if the patient is planning to get pregnant later on, you need to wash out all the leflunomide in the body because it can be stored in there. It's category X, again, teratogenic, absolutely unacceptable in pregnancy. So you need to the patient taking such drugs needs to be on contraception because we cannot risk her getting pregnant, and we need to wash out all the flavonoid. Again, hepatic metabolism, interhepatic recirculation, elimination in the bile and the urine. Contraindicated, as we said, in the pregnancy, severe hepatic impairment because again, metabolism is hepatic, bone marrow dysfunction, and immunodeficiency because it's affecting T cell lineage. So we cannot give it to immunodeficient patients. It's oral medication and we monitor blood pressure. Adverse effects, diarrhea, hypertension, which is why we need to monitor blood pressure. Hepatotoxicity, it has adverse effect on the liver, so you cannot give it in severe hepatic impairment. And teratogenic, category X, unacceptable, you need to wash it out and give contraception, come on. Now, we have two more, sulfasalazine, hydroxychloroquine, usually given with methotrexate because methotrexate is our anchor. So this is the main thing we give in such patients. What you need to remember is sulfasalazine will be metabolized to sulfapyridine and 5-ASA. Now, sulfapyridine will decrease all those inflammatory cytokines, including IL-1, IL-6, TNF-alpha, IL-12, all those inflammatory cytokines, decrease proliferation, decrease APC maturation. Basically, it's inhibiting cytokines, inhibiting inflammatory response, safe in pregnancy. Finally, if you have a patient with who is pregnant and she needs to take DMARD, sulfasalazine right away. It has some GI effects, leukopenia, reversible oligospermia. So it's safe in pregnancy, but can affect the sperm levels in the male. Back. And it's can cause rash. So main thing you need to remember, anti-inflammatory. It's a DMARD, but it decreases the inflammatory cytokines and it's safe in pregnancy. Hydroxychloroquine. It has an unclear mechanism of action. Thus, they think that it's mainly lysosomotropic, so it increases the pH in the lysosomes, so it decreases antigen processing. So usually the lysosomes will take those antigens, they will process them, they will present them, and it will cause the activation of the T cells, B cells, releasing all the antibodies, and basically the inflammatory response. Now, you're increasing the pH, decreasing antibody processing, antigen processing, decreasing antibody production, and all of that. Main side effects you need to remember: hydroxychloroquine, retinopathy. It affects the retina, so you need to do an ophthalmology exam annually whenever you're giving hydroxychloroquine. There are two words you need to remember from those slides: safe in pregnancy with sulfasalazine, retinopathy for hydroxychloroquine. Now you can give triple therapy, which is methotrexate with sulfasalazine and hydroxychloroquine, which is effective for moderate. And sometimes they say it's equivalent to methotrexate and biologic. It has lower cost and it's oral administration and safe. But you need to monitor some levels, including CBC, LFTs every 3 to 6 months, because as we said, most of those drugs are affecting the liver, side effects including hepatotoxicity, ophthalmology annually for hydroxychloroquine. Now, Dr. Hatouf had some questions in her slides, which, not in her slides actually, in the recording, but not in the slides. Go over them, in my opinion. 50-year-old woman has bilateral hand pain and 90 minutes of morning stiffness, not on any medication, and is awaiting her first rheumatology appointment in 3 weeks. Most appropriate initial management to relieve her symptoms. You can pause. Here, silcoxib, which is an NSAID for symptomatic relief. NSAID, symptomatic relief. 60-year-old man with arthritis, worsening wrist pain, morning stiffness, despite taking methotrexate weekly for 6 months. So, خلاص, he gave it a chance. 6 months, it's not working. He needs rapid symptom relief while awaiting for DMARD adjustment. So now they're adjusting his DMARD, but he needs something in the meantime till the adjustments actually start working. Most appropriate short-term intervention? Basically, she's just asking for bridging therapy. Begin prednisone daily for 4 to 6 weeks and then taper. You cannot stop it suddenly. Taper. We finished the first section. Second section of Dr. Hatouf's lecture, TNF-alpha inhibitors. Now we moved on to the biologic demons. They affect either TNF-alpha or non-TNF-alpha. TNF alpha, we have adalimumab, infliximab, and etanercept. Non-TNF, we have rituximab, tocilizumab, and abatacept. Animab is a monoclonal antibody. Etanercept, those are fusion proteins. Abatacept, fusion proteins, we'll discuss in a bit. TNF alpha inhibitors. Adalimumab, infliximab, etanercept. This table has everything you need to know. But technically, you don't need to go into too much detail. All you need to know is here. Adalimumab, fully human monoclonal antibody. It's fully human. So there is no risk of any immunogenicity or response to adalimumab compared to infliximab. Infliximab is chimeric. So it's 75% human and 25% mouse. So this mouse part can cause an immunologic reaction in the body. So you must use methotrexate to increase the immunogenicity because, as we said, it's chimeric. So there's a risk of reactions and anaphylaxis you give with the methotrexate. Now, adalimumab is subcutaneous, infliximab is IV. Etanercept is a soluble TNF receptor fusion protein. As we said, MAB is monoclonal antibody. Etanercept, this is a fusion protein. Etanercept is TNF alpha inhibitor, so you need to remember that. Etanercept is a fusion protein for TNF receptor. Again, given subcutaneously, you need to screen for TB with skin test or the interferon gamma release assay, and you do chest X-ray. You need to check the patient does not have TB because TNF alpha is important to contain the TB infection. If you inhibit the TNF alpha, you're risking that the patient's risking activating or aggravating any TB infection in the body, and this will cause the way worse effect for the patient. So you need to make sure the patient doesn't have tuberculosis. Black box warning, severe infections and malignancies. Again, we are reducing the immune response, so it's contraindicated in active infections. Untreated TB, do not give live vaccines because all those need immune response. And if you're inhibiting it by TNF alpha inhibitors, you are risk aggravating another underlying disease. So it can cause bacterial infection, TB reactivation, fungal infection, opportunistic infection, and malignancies. Which is controversial. Non-TNF biologics. Now, again, biologics, we are attacking something like the cells, the inflammatory response in the body, but non-TNF. So we said adalimumab, infliximab, and etanercept, TNF alpha. Rituximab, tocilizumab, and abatacept are non-TNF alpha biologics. Rituximab is anti-CD20, which is CD20 is basically a marker on B cells. So this is a monoclonal antibody against a marker on B cells. So it causes B cell depletion, decreasing autoantibody production, including rheumatoid factor, anti-CCP, and antigen presentation and T cell activation. So this is a monoclonal antibody against CD20. Anti-IL-6 receptor monoclonal antibody. So tocilizumab is against IL-6. Both are monoclonal antibodies against different things, not TNF alpha. So anti-IL-6, so it decreases the acute phase reactants and osteoclasts. And we have abatacept. Abatacept, again, we said cept is a fusion protein. So we said etanercept is TNF alpha. Abatacept is non-TNF. So it's a CTLA-4 Ig fusion protein. Blocks T cell co-stimulatory signal. What is happening here? Let's take a look. So we said rituximab against CD20 in B cells causes apoptosis. So now you cannot activate the effector cells. You cannot produce the antibodies. And here we have tocilizumab, which is anti-IL-6. So this is a monoclonal antibody against IL-6. So IL-6 now can't bind to the receptors and cannot continue the signal transduction. So it will calm the inflammatory storm. Abatacept, this is a fusion protein. CTLA-4 Ig fusion protein means it's a fusion between CTLA-4 domain and the Fc portion of IgG. Now what it's doing is it's binding to CD86. CD86 on APCs, and it's preventing the binding to CD28 on the T cells. So it can't really activate the T cell. So now we can read it here and hopefully it will make more sense. It blocks the T cell co-stimulatory by binding CD80, CD86 on antigen presenting cells, which prevents CD28 engagement. So it prevents CD28 engaging with this because it's binding to CD80, 86. And the way I remember this is abatacept ATA 8. I don't know how, I hope this works for you, it worked for me. So 8, so there's a lot of 8. So it binds to CD86 and 80 and prevents CD28, a lot of 8s here. And there's a fusion protein because it ends at sept. And for rituximab and abatacept, combination with methotrexate increases efficacy. Sorry. So this is those two are IV. Tocilizumab can be subcutaneous. Again, we require TB screening, hepatitis B virus screening, vaccinations, and infection monitoring because increased risk of infection. Okay. Another Dr. Hatuf question before we move on to the last part of Dr. Hatuf's lecture. 45-year-old woman presents with 4 months of symmetric joint pain in metacarpopharyngeal and proximal interpharyngeal joints with prolonged morning stiffness, positive rheumatoid factor, anti-CCP. Most appropriate initial pharmacological management. Few seconds. Okay. Most appropriate, you give methotrexate weekly because this is the anchor. You give folic acid as rescue with methotrexate and prednisone daily, and then you taper it. So this is the main treatment for rheumatoid arthritis. 45-year-old woman has been on methotrexate for 6 months, presents with fatigue and elevated AST and ALT, and she drinks wine daily. What do you do? Discontinue methotrexate because elevated LFTs sign that there may be an effect or pathotoxicity due to methotrexate, and you need to counsel an alcohol abstinence because alcohol increases the risk of cirrhosis. With methotrexate, you're basically just destroying your liver. Finally, the targeted synthetic DMARDs, which are JAK inhibitors. Benefit is that they're oral because as we saw in those tables, IV, subcutaneous, IV, subcutaneous. JAK inhibitors are oral. They inhibit the JAK pathway, so you are decreasing the inflammatory cytokines. It's a whole pathway, so it involves JAK and STAT, phosphorylation, everything. I don't think you need to know all this in details, but you can see it in the diagram in the slides if you'd like to learn more. But basically, you're inhibiting again the inflammatory response through the JAK-STAT pathway. JAK inhibitors usually end with INHB. We'll see in the next slide. You are decreasing immune cell activation and cytokine production. So they're all basically doing the same function through different pathways. This one is for the JAK-STAT pathway. Previous ones are for either the B cells or the T cells or folic acid. So different pathways for the same result in them. So tofacitinib, baricitinib, opadacitinib, filgotinib. INHB, the NIB is usually a suffix for the small molecules. So all those small molecule inhibitors end with INHB. So for the sake of the structure, just remember if it ends with INHB, it's a JAK inhibitor, which is a synthetic DMARD, a targeted synthetic DMARD. They're all oral, as we said. Upadacitinib is selective for JAK1, so it has less adverse effects. Filgotinib is selective for JAK1 too. So just remember, INHB, JAK inhibitor, TSDMARD, and Opada and Filgo are the selective ones. Again, they have adverse effects, black box warning, increased major adverse cardiovascular events, MACE, MI, stroke, and cardiovascular death, malignancy, and thrombosis, especially with tofacitinib. Tofacitinib has increased risk of thrombosis. So as we said, the more selective ones have less risk. So you need to adverse in older, you need to avoid in older patients, current or former smokers, cardiovascular risk, malignancy, and thrombosis history. So basically, you need to remember that there is increased risk of cardiovascular events and malignancy and thrombosis, especially tofacitinib. So the way I remember this, again, I hope it works for you. Tofacitinib reminds me of tofi. I'm imagining tofi getting stuck in your blood vessels, thrombosis, thromboembolism, and so on. faster thrombosis. If methotrexate fails, TNF alpha inhibitors should be first line. JAK inhibitors are last resort if they are ineffective or the other drugs are contraindicated. JAK inhibitors, last resort. It's usually methotrexate. If not methotrexate, TNF alpha inhibitors. Again, you have other risk factors. I usually work with visual clues, which is why I keep including such stuff. So other risk for infection, hematologic like anemia, dyslipidemia, increasing total cholesterol levels, GI effects, and hepatotoxicity. So you need to monitor the baseline for all whatever would be affected by all those. So CBC for anemia, lipids for the cholesterol and LDL. You need to monitor for TB, HBV, HCV. Again, for the risk of infections and liver damage, hemoglobin should be above 9 because it can cause anemia. And you need to vaccinate the patient against Shingrix against varicella zoster, pneumococcal, and influenza before starting because increased risk of infection while on the drugs. In conclusion, step one, main thing, is methotrexate monotherapy with folic acid. Again, you can give bridging therapy with prednisone. Step two, if there's inadequate response, although you give it enough time for 3 months or so, you add a biologic DMARD, which could be TNF alpha inhibitor or non-TNF alpha, or a targeted synthetic DMARD. Step three, if everything is if the previous management was ineffective, you switch to a different biologic with a different mechanism of action. And you always need to screen for TB and HBV. You will need to monitor the CBC and the liver enzymes, and you vaccinate before biologics. This is the main takeaway message. Now, end of the lecture, so we have 2 questions. Which of the following is safe in pregnancy? Very short question, straight to the point, very important. Sulfasalazine. Methotrexate category X, adalimumab, rituximab, you cannot give TNF alpha inhibitors. So sulfasalazine, safe in pregnancy. In which of the following drugs you should perform eye examination before prescribing it to the patients? Very high and very important, very specific side effect, only for hydroxychloroquine. So whenever the patients have hydroxychloroquine, you perform eye examinations. Now, moving on to the 4th lecture, which is technically the 5th for you. So congrats, we're halfway through. Inshallah, to me, the first part was the hardest, the longest, most detailed. Everything else is going to be easier, inshallah. So, hang on. Gout. So, gout, you have, let's do a general overview. Gout is basically build up of uric acid. So you have uric acid building up, which will start crystallizing when it exceeds a certain limit. Again, I have extra details in the notes beneath the slides if you'd like to read more about the topic, but let's focus on the most important things. So most of uric acid is excreted by the kidney and the rest is by the intestines. Uric acid is more soluble in urine, but it's affected by the pH. So after a certain pH, the solubility will decrease, and now the uric acid will start building up. And urate crystal deposition occurs when circulating uric acid exceeds its rate of solubility. What does that mean? At to 6.8 milligrams per deciliter rate of solubility, this is the maximum until which the uric acid can be soluble or dissolved. Now, if we exceed that, uric acid cannot be dissolved in the body. So now it will start building up, forming crystals, which will produce gout. So now those urate crystals will start depositing. And yeah, so when does this happen? When does gout happen? You either have overproduction of uric acid or under-excretion. Under-excretion is the most common cause. So uric acid is being formed normally, but you're not really getting rid of it properly. And this will cause buildup, or you have too much uric acid being produced. Now, we have different drugs attacking gout from different perspectives, either attacking the overproduction and attacking the under-excretion, but we'll cover them in a bit. One by one, بس يعني, what are the general stages of gout if it's untreated? You have, first of all, it starts with asymptomatic hyperuricemia. And then you have acute gout, in which you have rapid onset and escalation with joint pain. So the patient will have severe pain over, for example, 12 hours and then peaking within 24 hours. Severe pain in one joint, for usually the big toe. This is the main joint that's affected. It can be in other joints though, mainly. And then you have intercritical gout, which is the time where the patient is asymptomatic between the flares. And you have the chronic tophaceous gout, which is hard uric acid deposits under the skin. As you can see here, this is tophaceous gout, so tophi deposition. It contributes to bone cartilage destruction, and it can even affect, gout in general can affect all body system. So it can affect the kidneys, can affect the heart, can affect so many things. But this is the general appearance of the joint during a flare. This is the negatively birefringent crystals, and those are the tophi. Now, interval between the first and second gout flare is usually within 1 year, but can be less frequent. And we have different triggers. For example, food rich in purines, because uric acid is produced from purines. So if you have food rich in purines, like red meat and so on, you are increasing uric acid in your body. You have high intake fructose corn syrup, because fructose is the main or only carbohydrate that is high, that would produce uric acid. So high intake fructose corn syrup will increase risk of gout. Alcohol, because the intake will increase the increased intake will increase the risk of gout, because alcohol is high in purines. And the patient has kidney problems, because obviously we need the kidney to excrete uric acid. Medications such as aspirin competes for excretion. So you can give NSAIDs in certain conditions, which we'll talk about. However, not aspirin, because aspirin will compete with gout for excretion. And sorry, cyclosporins and diuretics. Also dehydration, because this will cause crystallization of the uric acid. Overweight, because if a patient has high belly fat will have more inflammatory chemicals compared to subcutaneous fat. Those inflammatory chemicals can increase the progression of gout. And physical stress. Now for the actual management we care about. Now we need to reduce the pain and the inflammation. We need to reduce uric acid levels in blood or prevent future attacks. So those are the gout drugs. We have chronic gout drugs, which are preventative, or we have acute gout drugs, which in which we need to abort right now the pain. So you have acute and chronic. And to remember the difference between them, we have this mnemonic: all painful flares are preventable. So all allopurinol, P for pegloticase, F for febuxostat, and preventable for probenecid. So this is for prevention for chronic gout. Acute gout drugs, NSAIDs, glucocorticoids, and colchicine. And again, we have this diagram. Allopurinol and febuxostat will act on xanthine oxidase. We have diuretics and probenecid on different areas, which we'll talk about now. Starting with the acute drugs. So you have a flare right now, which can happen randomly. And basically, it happens randomly. It may last anytime between 1 to 2 weeks, even. And it can go several months or years between the attacks, as we discussed, but usually no long-term damage unless it's repetitive and chronic. And tends to start in the big toe. Treatment aims to reduce inflammation, and those drugs are initiated immediately after the onset of gout attack. Those drugs only. You do not give the chronic drugs for acute gout attack. Why? Because if you have an attack right now and you give those chronic treatments, you are just for example, displacing the crystals and aggravating the pain in the patient. So we do not want to do that. We only give those 3 drugs during an attack. NSAIDs, glucocorticoids, and colchicine. So, starting with NSAIDs. Again, we have the same diagram we discussed previously. So we have indomethacin, ibuprofen, and naproxen, not aspirin. As we said, aspirin can compete with the excretion, so you do not give it for gout. And if the patient has a gastric ulcer, celecoxib, as we said, it has less risk of GI effects, but increased cardiovascular risk. Remember that. Again, this is exactly what we mentioned. Glucocorticoids, they act on the phospholipase A2, as we mentioned, also in the rheumatoid arthritis lecture. Inhibits phospholipase A2, decreases prostaglandin synthesis, decreases inflammation. You have either oral or parenteral, oral including prednisone and prednisolone, Parenteral or IM, if the patient is NPO, so the patient cannot take oral medication now, you have to give them IM or parenteral, which is methylprednisolone. And for some joints, if the joint is accessible, you can even give intra-articular glucocorticoid. Now for colchicine. Colchicine is the third acute drug management we have. It reduces inflammation and pain in acute attacks and also for prophylaxis of gout attacks, so it's used for both. It stabilizes tubulin subunits and inhibits microtubule polymerization. Let's look at this. Colchicine, it will inhibit depolymerization or polymerization of the tubulins. Now, tubulin is found in different structures in the cell. So if you inhibit tubulin polymerization, you are inhibiting many things in the cell. You are inhibiting the neutrophil activation, neutrophil migration, because you need the tubulins for the cell migration. You are inhibiting cytokine release, inflammasome formation, and reactive oxygen species formation, and leukocyte So basically, you're inhibiting inflammatory response and the movement of the cells themselves. This is done by stabilizing the tubulin subunits. So you inhibit the inflammasome activation, microtubule-based inflammatory cell chemotaxis, and generation of leukotrienes and cytokines, and phagocytosis in joints. Why? Because inhibiting neutrophil activation and migration, and also cytokine release. So it has some side effects, which are GI side effects, nausea, vomiting, diarrhea. We have bone marrow suppression, because as we saw, we're affecting neutrophils, we're affecting cytokines, reactive oxygen species, we're affecting everything because tubulin is found in the cell in different pathways or different, it's needed in different places. So it causes bone marrow suppression, rhabdomyolysis, which is the muscle breakdown, kidney damage, and polyneuropathy. Again, the nerves have also need the tubulin subunits, so it will cause damage to the nerves, damage to the kidneys, to the muscles, to the bone marrow, to the GI, so it's affecting all systems. It's contraindicated in severe renal impairment when the creatinine clearance is low, in hepatic impairment, and in concomitant renal and hepatic disease. So this is your cue. Remember, kidney and liver. You cannot give colchicine. You cannot give colchicine in kidney disease, liver disease. Again, as you said, homocysteine inhibits everything. Leukocyte movement leukocyte movement into the area, neutrophil migration, so it causes bone marrow suppression. All those effects due to tubulin. Now we have chronic gout. If the patient presented with an attack right now and they need to be managed, we discussed the drugs. Now, long-term management. So in chronic gout, the patient has chronically elevated uric acid, which leads to tophi deposition, as we saw in pictures in the previous slide. And this tophi deposition, also kidney stones, because uric acid can crystallize and form kidney stones. Kidney stones could be due to calcium, due to uric acid, oxalates. There can be many different things, including uric acid. And it can also cause bone and joint damage. As we said, it crystallizes, stays in the joints, and now it can damage the joint itself. Treatment is by urate lowering therapy. First line is xanthine oxidase inhibitors, which is allopurinol. Allopurinol is the first line for chronic gout. Second line will be uricosurics, probenecid, which increases the excretion of uric acid, as we saw in this diagram here. Increases excretion. Why? By inhibiting the reabsorption of uric acid, so more of it is getting excreted into the urine. And third line is recombinant uricase. So uricase enzyme is rasburicase, pegloticase. Those are the enzymes which we will discuss. Again, not given during an attack. Starting with allopurinol. It's a competitive inhibitor of xanthine oxidase. So it competes with the substrates for this enzyme, which is xanthine oxidase. It prevents gout attack, but again, do not give during the attack. If you inhibit xanthine oxidase, we are decreasing the production of uric acid. So now, less uric acid, less risk of crystallization in gout, and so on. And increased fluid intake lowers the incidence of acute urate nephropathy. So it's decrease the conversion of hypoxanthine and xanthine to urate, also used in lymphomas, leukemias. We do not care about this. Prevent tumor lysis associated urate nephropathy. So if if you have a tumor and you're giving chemotherapy and medication, you are increasing production of many different substances. But for now, we care about the uric acid. You are increasing, so there will be hyperuricemia. So this will prevent tumor lysis associated uric nephropathy. And you also give increased fluids, so the patient will take fluids, decrease the risk of dehydration and crystallization. Adverse effects, you need to remember rash, Steven-Johnson syndrome, or toxic epidermal necrolysis. They're basically the same thing, but it depends on how much of the body is affected. Less than 30% of the body that has this rash and this side effect is Steven-Johnson syndrome. If more than 30% of the body is affected, toxic epidermal necrolysis. But they're basically the same thing, which is this rash, remember it. And GI problems. Febuxostat also acts on xanthine oxidase, thus it's an alternative non-purine selective inhibitor. So again, here you have a mnemonic. Febuxostat makes xanthine oxidase static. So we are inhibiting xanthine oxidase, but allopurinol was a competitive inhibitor. This one is a selective inhibitor, but it's non-purine. It's not exactly competing with it. Contraindication is cardiovascular disease. You would not give it with cardiovascular disease. Adverse effect again GI, increased hepatic enzyme level and rash, which is rare. But mainly remember allopurinol. Now we have one warning, which is drug-drug interactions. We said allopurinol inhibits xanthine oxidase to decrease uric acid, and we're decreasing uric acid. Life is good. But remember that xanthine oxidase is also used for other things. So azathioprine and 6-mercaptopurine are immunosuppressants that are also inhibited by xanthine oxidase. So if you inhibit xanthine oxidase, now those things, azathioprine and its metabolite 6-mercaptopurine, can't be broken down. They start building up. So if they're there, they will be like, okay, might as well continue doing my job. They will start building up in the blood. They are immunosuppressants, so it can cause bone marrow toxicity. We need to get rid of azathioprine and 6-mercaptopurine to avoid bone marrow toxicity. If you're inhibiting the enzyme that is metabolizing them, you are decreasing the risk of buildup. So you need to avoid combining xanthine oxidase inhibitors like allopurinol with azathioprine or mercaptopurine. Or you reduce the dose if using xanthine oxidase because you know it's going to start building up, so no need to have high doses. You can reduce the dose if you absolutely have to use them together. And also probenecid and thiazides decrease the efficacy of allopurinol because probenecid, as we said, it will increase the excretion. It may also increase the excretion of one of the metabolites of allopurinol, so it will decrease the efficacy of allopurinol. Again, thiazide is a diuretic, same thing. And also thiazides is one of the side effects of thiazide is to increasing uric acid levels. So if you're giving xanthine oxidase inhibitors to decrease thiazide to decrease uric acid levels, and then you end up giving a diuretic that increases uric acid levels, what are you doing? Now, we also have uricosurics. Uricosurics, we have probenecid, which is one second here, which is used as an alternative to or in combination with xanthine oxidase inhibitors. We have probenecid and sulfenperazone. Inhibition, its main mechanism of action is to inhibit uric acid reabsorption. So uricosurics, you're increasing uric acid in the urine. تمام? You inhibit the reabsorption in the renal proximal convoluted tubules because most of the reabsorption happens in the PCT, proximal convoluted tubules. To inhibit reabsorption there, you increase the elimination in the urine. So probenecid inhibits URAT1 and OAT1. So here you have URAT1 and OAT1. Sulfenperazone inhibits URAT1 and OAT4. URAT1 and OAT4. Those are just subtle names you need to remember. That's basically inhibits reabsorption of uric acid in proximal convoluted tubule. Can precipitate uric acid calculi or lead to self-allergy. So sometimes it does have the side effect, as we mentioned, it can precipitate the calculi and cause the stones. Adverse effect, urolithiasis, as we said, it can precipitate the uric acid calculi. It will cause the buildup and cause the bones. It will cause the stones being formed, which is curative cases. It can cause hypersensitivity reaction because sulfur allergy due to being sulfonamide derivative. So as we said here, this drug has is a sulfur compound, and usually sulfur compounds, including, for example, probenecid, they would cause hypersensitivity in certain patients. GI and rash, drug-drug interactions. So it's a weak acid and competing with secretion in the proximal convoluted tubule. So it will inhibit the uric acid reabsorption, increase excretion, but it will also compete with other compounds for secretion. So it will compete with penicillins and cephalosporins and aspirin. So it will compete with them. So instead of those being secreted, this compound will be secreted instead. So they will start building up, and this will have adverse effects for the patient. So you try to avoid combinations. Contraindicated in patients with moderate to severe CKD. As you can see, this the uric acid's main action is the renal tubules. So the kidney is damaged. There is severe chronic kidney disease. You can't moderate to severe. You can't give uric acidics. And it's important to maintain a daily urine output of 2 liters or more to minimize precipitation and nephrolysis. So as we said, it can precipitate the stone formation, uric acid stones. So you keep giving the patient fluids and water and water. You need to maintain a good urinary output to prevent any chance of those stones building up and causing nephrolysis. Now we also have the recombinant urate oxidase. So those are enzymes, ases, urate oxidases. So we have rasburicase, pegloticase. So those are enzymes. So they are uricase. They catalyze the enzymatic oxidation of uric acid into soluble and inactive metabolite allantoin. So allopurinol inhibited the formation of uric acid. Probenecid increases the excretion by decreasing the reabsorption. We have certain enzymes that will convert our uric acid into something more soluble, so it won't precipitate and cause the crystals and gout and the uric acid stones and all those. So this will convert the uric acid to allantoin, which is soluble and inactive, and inactive metabolites. So it will rasburicase will lower the uric acid more effectively than allopurinol. It's also given in pediatric patients with malignancies on anti-cancer therapy. So as we said, tumor lysis, when you break down the tumor, for example, with chemotherapy, you are risking increased, for example, hyperkalemia, hyperuricemia, hypocalcemia, such effects. We care about hyperuricemia in this lecture. If you're increasing the uric acid levels, you need to give medication to counter that effect. So you can give rasburicase in patients, cancer patients on anti-cancer therapy to decrease the hyperuricemia. So it's given in the hospital, it's not a pill, so it's given IV. Pegloticase is a pegylated recombinant mammalian uricase. So it essentially does the same thing, but it's pegylated, and we'll discuss this in the next slide. But usually, if when do we give this? If the first line and the second line medication fail, as we said here, first line is xanthine oxidase, second line is uric acidase, and then third line is recombinant uricase. So you give if they fail, and if the patient has frequent gout attacks, more than 2 per year, and persistent subcutaneous tophi. So you need خلاص to go to the last resort. It can cause infusion reactions, as we said, it's أصلا given in the hospital, including anaphylaxis too. Should not be used concomitantly with xanthine oxidase inhibitors or uricosurics. So as we said here, yeah. So you do not use them concomitantly because allopurinol works on decreasing the levels of uric acid. Pegloticase and rasburicase want to convert the uric acid to allantoin. So you can't really convert something that isn't there. You're inhibiting with another drug. So you don't really give them together. Allopurinol will decrease uric acid. Uricase will try to convert the uric acid to allantoin. So you don't really give them together, because you need to have this for the other drug to work. تمام. Difference between them. Pegloticase is pegylated, so you add the peg to the enzyme to increase its half-life from 8 hours to 10, from about 8 hours to 10 to 12 days. This modification allows for administration just once every 2 to 4 weeks, because now it's a large compound and it's not getting excreted, it's staying in the blood, staying in the body, I mean, So now you can just give it once every 2 to 4 weeks and خلاص it's staying in the blood. So this makes the drug suitable for long-term treatment. So the patient doesn't have to go for IV or injection or whatever every very frequently. You can just give it once every 2 to 4 weeks. Adverse effects, as we said, anaphylaxis. It can also cause methemoglobinemia and hemolysis in G6PD deficiency. Why? Because basically what's happening here is uric acid is converted by uricase to allantoin, but it also produces carbon dioxide and H2O2. Hydrogen peroxide is the active oxygen species. So this can cause oxidative stress in the body, causing hemolysis in G6PD deficient patients, and it can also convert ferrous to ferric iron, which is essentially what's happening in methemoglobinemia. So it will cause methemoglobin in the body. Now, this is what the summary Dr. Samah had. Go through it. Pharmacotherapy treats pain, inflammation, reduction of uric crystals in the body. NSAIDs, colchicine, and glucocorticoids for acute, urate-lowering drugs to prevent in chronic gout. Xanthine oxidase inhibitors or uricosuric agents during acute gout flare may worsen the symptoms by mobilizing the crystals, as we said. Colchicine and NSAIDs, glucocorticoids administered before initiating the urate-lower therapy because they are the acute management, that's the chronic management. And you start preventative treatment 1 to 2 weeks after a gout attack. Recombinant urate oxidases are used to prevent high blood levels of uric acid from occurring in pediatric and adult patients with leukemia, lymphoma, and solid tumor malignancies receiving anti-cancer therapy. As we said, anti-cancer therapy destroy the tumor. Now the tumor will start releasing multiple things, including uric acid. We need to decrease. 2 questions, end of the lecture. A patient presents with an acute gout attack, prescribed colchicine. What is the primary reason for using colchicine? Basically, what is the mechanism of action? Does it increase excretion, decrease migration, reduce production, or inhibit prostaglandin? We said decrease granulocyte migration because it acts on tubulin. What does inhibiting the xanthine oxidase do to PRPP? This is a question I think my batch got in the exam. What is happening is, okay, my laptop is dying. So anyways, what is happening is basically decreased phospholipid pyrophosphate. Why? Because you are inhibiting xanthine oxidase here. So hypoxanthine is starting to build up. Now, in this pathway, remember this picture also. In this pathway, hypoxanthine is starting to build up. So now it will go back to the purine salvage pathway. Now, when it goes back, it's basically reacting with phospholipid pyrophosphate to form IMP, and then it will continue the pathway because it can't go through this way, so it has to go through the other way it has, which is here. So now it's reacting with phospholipid pyrophosphate to produce IMP, so PRPP levels are decreased. Now we have our 5th lecture, Myasthenia gravis, 3 lectures left. Short break, and I'll be back with you, inshallah. Yep. Assalamu alaikum, everyone. Let's continue the last 3 lectures. Myasthenia gravis next. Again, starting with a general overview. We have what basically is happening in myasthenia gravis. Nerve endings that release ACH. Basically, nerve endings are releasing acetylcholine, which travel through a neuromuscular junction and then bind to the N receptors, and this will cause muscle contraction. However, what we have in myasthenia gravis is basically there are autoantibodies blocking those receptors. They are blocking or destroying the receptors. So now the postsynaptic surface has decreased the number of receptors, and there is no signal transduction in the neuromuscular junction. So there is no muscle activation. And this is what causes the muscle weakness, the fatigue, droopy eyelids, blurry vision, and limited facial expressions and trouble walking in myasthenia gravis, trouble walking and even speaking in myasthenia gravis patients. We have some drugs that may unmask or worsen myasthenia gravis. Just know them. They will help you in the future, but they're less likely to get you such questions on those drugs. But yani, it's good to know those drugs. Now, again, what we do is we test the patient with the bedside maneuvers. what was that point here? Yeah. Uh, we do a bedside examination and maneuvers. We check for the presence of the N receptor antibodies. So we check for anti-acetylcholine receptor antibodies, or also anti-MuSK antibodies in 4% of the patients, or anti-LRP in 2%. Again, this is more with clinical pathology, but it's good to know as a general overview for now. We do an electromyogram. So we see a decreased response with repetitive nerve stimulation. You keep stimulating the nerve, but you have less and less acetylcholine actually binding to the receptors every time because the receptors are getting destroyed. And we do an imaging CT or MRI of the thorax to evaluate the thymus because some patients have thymoma, which will cause the increased autoantibody release, and this will cause the manifestations of myasthenia gravis. And the edrophonium test, which is tensilon test. This is very important because edrophonium is a short-acting acetylcholinesterase inhibitor. So it inhibits acetylcholinesterase, inhibits the enzyme that breaks down acetylcholine, increasing acetylcholine levels in the junction. So after its administration, we have increased acetylcholine accumulates and then temporarily increases the strength. So if a patient has typical symptoms of myasthenia gravis, so you're not sure if this is it, you give edrophonium, they improve. This is a positive test, and the patient probably has a myasthenia gravis. So as you can see, before administration, they have droopy eyelid, and now it's opening. But sometimes it has false positives and risks. So treatment options again, we have symptomatic, like anticholinesterase agents, have chronic immunomodulating, rapid immunomodulating, and surgical. Starting with the symptomatic, which is anticholinesterase agents. This is the first line in myasthenia gravis. So again, it's for symptomatic management, but does not affect the immune process or the pathophysiology itself. It inhibits acetylcholinesterase. Acetylcholinesterase is the enzyme that breaks down acetylcholine. We're inhibiting it, increasing acetylcholine in the junction. And this will activate the acetylcholine receptors because now we have increased acetylcholine, more activation of the receptors. So there's partial improvement, but it wanes after weeks to months of treatment. We have two acetylcholinesterase, neostigmine, pyridostigmine. Both very important, remember them. What is the difference between them? Neostigmine is short-acting, and there's poor GI absorption, so it's used if pyridostigmine is not available. Pyridostigmine is intermediate acting, which is preferred over the short-acting and the long-acting drugs. We want something in the middle. So they will increase the acetylcholine. A good mnemonic to remember for future reference, stigmine, neo-CNS, no CNS penetration. So it does not go into the brain or CNS. Again, it's used for myasthenia gravis and reversal of neuromuscular junction blockage. And pyridostigmine, here again we have it increases acetylcholine, increases muscle strength, and this is a point we'll come to in the last slides. We'll discuss that. Now, it has nicotinic action and muscarinic action because they increase the acetylcholine in the synaptic cleft. So we have nicotinic action. So in therapeutic doses, this nicotinic action means it's action in the muscles. It will increase muscle contraction. In toxic doses, it will lead to relaxation and paralysis of the muscle. Muscarinic action can be remembered by dumbbells. So dumbbells is usually for the toxicity levels, but this is also the actions. So it will cause diarrhea, urination, meiosis, bronchospasms, bradycardia, emesis, lacrimation, sweating, and salivation. So it will basically increase the secretions, open all the sphincters. It will cause diarrhea, urination, meiosis, constricted pupils. And this is all reversed by atropine. So, nicotinic action, as we said, neuromuscular blockage. Adverse effects, we said muscarinic mostly. Nicotinic adverse effects are less likely, which include the fasciculations and the cramping. So to manage those adverse effects, you administer an anti-muscarinic like glycopyrrolate. So this is the point here. You control the pyridostigmine adverse effects by administering glycopyrrolate. So this will decrease the effect of acetylcholine in the junction, and this will help decrease the bronchospasm, salivation, diarrhea, meiosis, and so on. That's for nicotinic. Okay. For chronic immunomodulating drugs, we have yeah. So we have cyclosporine, tacrolimus, glucocorticoids, azathioprine, which we will talk about. But all those act on different parts of the T helper cell. So some act on the genes, some act on calcineurin, and some act on purines. Let's take them point by point, one by one. 1 second. My laptop is acting up. Sorry about that, guys. So I guess we can't use presenter mode anymore for some reason, but yeah, we can manage. So next we have chronic immunomodulating drugs. Now, here we have glucocorticoids. Glucocorticoids, most common is prednisolone. If we said the mainstay or the main management was acetylcholinesterase inhibitors, prednisone, predostigmine and neostigmine. Now, if those don't work, we can give glucocorticoids, which suppresses the formation of autoantibodies, which are basically causing the disease here, myasthenia gravis. So it decreases the severity of exacerbations and causes significant improvement in 1 to 4 months. And we discussed the management, the pathway or the mechanism of action of glucocorticoids multiple times previously, so no need to go over it again. And the adverse effects, as we mentioned, the high homie, remember him? Now, 50% of the patients may develop transient deterioration with possible precipitation of myasthenia gravis crisis. So first, when you first give glucocorticoids, this may cause it's a kind of a surge of the autoantibodies. So this will cause a transient deterioration for some days or for a short period of time. The patient will feel a bit worse, and then they will feel better. After that, when the immunomodulating effect of the glucocorticoids starts working. Now, next one we have is azathioprine. We talked about azathioprine once in the gout drugs. We said it's also metabolized by xanthine oxidase. Remember, and we said we can't give them together. So, which is why we have this interaction with xanthine oxidase inhibitors will cause toxicity. So, what is azathioprine doing, basically? It has a preferential T cell action with steroid-sparing effect. So what it does is it interrupts DNA synthesis and the proliferation of B and T lymphocytes. So let's go back to the diagram here. Inshallah, my laptop works this. Yeah. Azathioprine here will affect purine nucleotides. So this will affect DNA replication in the T cells. Okay. So it will interrupt DNA synthesis and proliferation of B and T lymphocytes, and its beneficial effect is in 6 to 12 months, again, chronic immunomodulating drugs. Maximum after 1 to 2 years, come on. It has some adverse effects like fever, nausea, and vomiting, but it's generally well tolerated. Problem is if we give it with xanthine oxidase inhibitors, it will cause toxicity. But again, because it's immunosuppressant, it affects the DNA synthesis, so it can even cause hematologic and liver abnormalities. So you need to monitor CBC, the blood counts, and the LFTs to make sure there is no effect on the blood and the liver. Okay. Next, we have calcineurin inhibitors. We have cyclosporine and tacrolimus. So cyclosporine and tacrolimus will block the synthesis of IL-2 and interferon by the T helpers. Again, as I showed you in the big picture, we're working on the T helper cell. Cyclosporine and tacrolimus will inhibit calcineurin. Calcineurin is needed for, again, uh, mRNA, DNA, and transcription and translation of certain inflammatory cytokines like IL-2 and interferon by the T helpers. This will Good thing is it gives us a faster clinical benefit. Remember how we said azathioprine needs 1 to 2 years? Come on. Cyclosporine and tacrolimus have a faster effect in 1 to 2 months. So they block the synthesis of IF2 and interferon gamma, but they have renal toxicity and interaction with other drugs, which is why they're not really used as first line. And tacrolimus is less nephrotoxic compared to cyclosporine, but both have renal toxicity, which really limits their use. Rituximab, we discussed rituximab in the non-TNF alpha DMRs. Remember, we said it acts on CD20, which is a marker in B cells. Again, so it's a monoclonal antibody against CD20 on B cells, first used for B cell lymphoma, and it also improves autoimmune disease. So we discussed the first autoimmune disease, which was rheumatoid arthritis. Now we're discussing myasthenia gravis. It's used for severe refractory myasthenia gravis. We tried everything, خلاص can't work, rituximab. It has some adverse effects, infusion reactions. With the first infusion, increased risk of infections, as we discussed previously. Mm, mm, because this is a call for help, I need a new laptop. Anyways, inshallah, we can move on to the next slide. Yeah. Rapid immunomodulating drugs. So we discussed the chronic immunomodulating drugs, which include azathioprine, calcineurin inhibitors, and so on. Now, for the rapid immunomodulating drugs, we need something that has a fast action, short term, right now. We need it right now. So we have IV immunoglobulins and plasmapheresis. Now, they are used in myasthenic crisis. So the patient is in crisis right now. We'll discuss what myasthenic crisis is in a bit. It can also be used pre-operatively before thymectomy or surgery, or periodically to maintain remission that is not well controlled. So patient is in a bad state. Oh, you need something really fast. You give rapid immunomodulating. It's temporary. It's not really affecting in the long run, but we need it right now. We have plasmapheresis, which is basically what you're seeing here. You are exchanging the blood. You are removing the plasma with acetylcholine receptor antibodies, which is a temporary treatment for those severe symptoms. You are removing those antibodies, and the effect is within days. But if you don't really manage it with immunotherapy and the main treatment, because the antibody levels can rise again. So this is only temporary. Now, IV immunoglobulins, if they're given in high dose, so they are antibodies to the acetylcholine receptor antibodies. So you have in myasthenia gravis, you have antibodies attacking the receptors. Now you're getting antibodies to attack those in order to prevent this effect. So large amount of IgG suppresses the autoantibody production from B cells. So you are giving large amounts of IgG. Now, this IgG will decrease the autoantibody production from B cells, which is basically what's happening in myasthenia gravis. Again, they have infusion reactions, renal failure, thrombosis, anaphylaxis. Now, myasthenic crisis. We need to differentiate between myasthenic crisis and cholinergic crisis. In myasthenic crisis, this is an exacerbation of the disease itself. Myasthenia gravis, but severe and right now. So this can be exacerbated by respiratory infection. Patient is pregnant. Patient is taking certain medication. Remember the medication we mentioned in the first slide: fluoroquinolones, beta blockers, all those agents, neuromuscular blocking agents. Those can precipitate myasthenic crisis. What is happening in myasthenic crisis is weakness, basically. Muscles are so weak. Even the respiratory muscles are weak, and this may even lead to difficulty breathing. Patient can't breathe, and they need to be intubated. It is intense muscle weakness. Meanwhile, in cholinergic crisis, this is a side effect of excessive management. So you're giving drugs to increase acetylcholine to a point that you're putting them in a cholinergic crisis. So, there is a paradoxical muscle weakening. Although you're trying to manage the disease and increasing muscle strength, there's paradoxical weakening in these muscles. But the difference between this and myasthenic crisis is you have the other side effects of the acetylcholine, as we said, meiosis, increased sweating, increased secretions, bradycardia, and so on. And to differentiate, we also have the tensilon test, which is the hydrophonia. So hydrophonia would work for myasthenic crisis and not cholinergic crisis. Now we're done. We're done with the lecture. So questions. 60-year-old patient with a history of myasthenia gravis presents to the emergency department with significant weakness. Patient is intubated. Which of the following tests can differentiate between myasthenic cholinergic crisis? We just mentioned it. This would be hydrophonia, which is the tensilon test. Next question. Patient with myasthenia gravis was started in periodostigmia, while their muscle strength improved, but the patient complained of abdominal pain and diarrhea. What can be added to the treatment regimen to manage these side effects? Basically, we're trying to manage the cholinergic side effects. So what do we give them? Glycopyrrolate. Because this will have anti-muscarinic action, decrease those effects, which is the diarrhea, sweating, lacrimation. Oh, done. Next lecture, we have skin infections. Uh, 1 second, and I'll be back with you. Okay, now last two lectures. Inshallah, this is going to be quick, easy lectures. Skin infections. Starting with an overview of skin infections. So you can either have bacterial, viral, fungal, or parasitic infections. We'll take them one by one and discuss the causative agents and their management, starting with bacteria. So we have different diseases caused by bacterial infections. We have impetigo, which, as you can see, usually is in mostly in young kids, but it can appear in other populations. It will cause crusting and yellow honey-colored lesions. Bullous impetigo, on the other hand, will cause bullae, which are fluid-filled and big. As you can see, they are again honey-colored yellow, but they're bullae. Cellulitis will cause skin reaction with hazy margins. You can see fever, erythema, sweating, and this is basically a skin infection, mostly caused by either strep pneumo or staph aureus. You have cutaneous abscess, and as we know, if you have an abscess, you need to drain it. Staphylococcal scalded skin syndrome, and basically a severe infection. It's a blistering disorder and affecting the epidermis. And folliculitis, as you can see here in the picture. So those are the main bacterial infections. What you need to know is first line for the bacterial infections is penicillin. Penicillins are broad spectrum bactericidals. As we talked previously, they inhibit the penicillin binding proteins. And flucloxacillin is used for penicillin resistant staph infections, except if we have MISA. What do we use? We use vancomycin. We have other alternatives, but mainly is vancomycin. We have some adverse effects for penicillins. We have cholestatic jaundice and hepatitis. So basically, there is a decreased movement of the bile. The bile will stay in the gallbladder. This will cause jaundice and hepatitis. You have higher risk. The risk of adverse effect is high with age and treatment for over 2 weeks and up to 2 months post treatment. So alternatives, if you can't give penicillin. So for example, as we said, we have when we had a patient who's allergic to penicillin, alternatives include cephalosporins, macrolides. As we said, so cephalosporins are broader. Macrolides are given if the patient is allergic to penicillin, because cephalosporins are still there is still a risk of allergic reaction. And coamoxiclav, which is amoxicillin clavulanate, which is given for periorbital and nasal cellulitis and bite-associated infections. Now, penicillin is usually given orally. Now we have some topical antibiotics. We have mainly two, mupirocin and fusidic acid. Mupirocin is a bacterial protein and RNA synthesis inhibitor. So basically, it It affects tRNA synthetase and causes cell death. All you need to know is it's a bacterial protein and RNA synthesis inhibitor. تمام? It's mainly used for staph and strep and impetigo. That's the first line for topical or small areas of acute impetigo. So usually if the patient has a limited disease, you can use anything topical to manage it. But if the patient has a very extensive disease, usually topicals don't work, and that's when you need to go for systemic therapy, like oral, IV, and so on. So here, if you have topical small areas of acute impetigo, as we said, if it's non-bullous, it can be strep infection or staph infection. If it's bullous, it's usually a staph infection. And in both cases, mupirocin is good. You have fusidic acid, which is also a protein synthesis inhibitor, and it's also used for localized impetigo. If it's long-standing or extensive, as we said, we need oral systemic management, flucloxacillin or macrolides if the patient is allergic to penicillin. Now, what if we have MRSA? So you can't really give flucloxacillin. If the patient is outpatient, you give them clindamycin or doxycycline or cotrimoxazole. Those have good if it's complicated or vancomycin resistant, which is the Versa basically, you give linezolid or daptomycin. Now we finished bacterial infections, moving on to viral. Two main viral infections we need to know. We said bacterial, main things we it's also a virus, so it spreads in a dermatomal distribution. So as you can see here, this is a dermatomal distribution, and prolonged infection. If you don't manage it, it can result in complications. So the patient can have post-herpetic neuralgia, where basically the area is very sensitive. Even if you blow at that area, they'd have severe pain. Management for viral infections, cyclovir. Usually cyclovir. So you have acyclovir, valacyclovir, pencyclovir, famciclovir. Acyclovir is the gold standard, which is a guanine analog, and it's highly specific to virus infected cells. So let's take a look at what exactly is happening in the cell. So here you have let me attempt to do a slideshow. So here you have acyclovir in the cell. Now the viral thymidine, okay, viral thymidine kinase will start phosphorylating acyclovir, and then the cellular kinase will continue the action of acyclovir, and this the final compound we have will terminate the viral nucleic acid chain, and it will inhibit the viral DNA polymerase. So its effect is only on the viral DNA because it needs the viral enzymes. It cannot rely only on cellular enzymes. So it needs the viral enzymes, so it only affects the viral DNA, which is why it's highly specific and it's the gold standard. It's good. Now we also have valacyclovir, which is a acyclovir prodrug. It has good oral bioavailability and it's also systemic therapy. Pencyclovir, on the other hand, is topical. So acyclovir, valacyclovir, you have oral. Pencyclovir is topical, and it has extended intracellular half-life, so it can stay for a long time. Famciclovir is a pencyclovir prodrug. Basically, it gets converted to the other drug. So it's again oral, and it has good dosing regimen. Mainly just remember acyclovir, valacyclovir. Other stuff, less high yield, low yield, basically. Fungal infections. Fungal is usually a dermatophyte infection. Now, you have tinea corporis, tinea pedis, and tinea capitis. Now, tinea corporis is basically ringworms of the body. So you have a circular patch and it's scaly and has raised margins or raised borders. This is usually tinea corporis. Tinea pedis is a fungal infection, dermatoid infection in the foot. So athlete's foot, you have scaling between the toes and the sole of the foot and so on. Tinea capitis is also a tinea infection, but in the scalp. Ringworm, there's scaling and hair loss, and this requires systemic therapy. Remember, tinea, usually you can do topical therapies if it's in the scalp or the nails, systemic therapy. So first of all, we have the oral antifungals, which are systemic for extensive cutaneous. Remember how we said if the patient has localized infection, you can do topical. If they have a very widespread infection, we need to do systemic. So extensive cutaneous, if there is nail involvement or unresponsive to topical treatments, this is where we need to do systemic. We have azoles, antihistamines, and griseofulvin. So azoles, we have fluconazole, itraconazole, and ketoconazole. Just remember the keywords. Fluconazole has good oral bioavailability and has CSF penetration. So if the patient has has a CNS fungal infection, for example, cryptococcus or whatever, you can use fluconazole because it goes to the CSF. Itraconazole is a broad spectrum for dermatoid infections, skin and the nails, and also for yeast infections. Ketoconazole has hepatotoxicity concerns. So this is why we don't really use ketoconazole systemically that much, because there is concern for hepatotoxicity. The way I remember this is just imagine a patient or a person on a keto diet and now they have a damaged liver. So ketoconazole, hepatotoxicity. Now we have allylamines. Allylamine, we have terbinafine and naphthepine. Terbinafine is oral, systemic, but it can also be done in a topical preparation. Same thing for naphthepine. Naphthepine is topical. But what they do is they have fungicidal action. They prefer it for onychomycosis. So if there is nail infection, nail fungal infection. Also for tinea corporis, pedis, capitis, cruris. So all of those, they can be managed by terbinafine. It's highly selective for fungal enzymes, selectively inhibiting squalene epoxidase. We'll talk about this in the next slide. And third oral medication we have is griseofulvin. So it is a historic agent for tinea capitis in pediatric patients. Pediatric patients, tinea capitis, griseofulvin was being used. Now, here we have the fungal cell. This is, in here you can see the function of the different antifungal therapy. So terbinafine will affect squalene epoxidase. So it will affect the conversion of squalene to squalene epoxide. And then squalene will start building up in the cell. This is cytotoxic. It will kill the cell. Meanwhile, azoles, azoles will inhibit lanosterol demethylase. So 14 alpha lanosterol, 14 alpha demethylase, it will inhibit the conversion of lanosterol to ergosterol. So this will affect the cell, the membrane fluidity. So now the cell again will die. This will inhibit replication, will affect the fungal cell. You don't really need to go into deep details. Just remember the enzymes, azoles for 14 alpha demethylase, allylamines, which are terbinafine, squalene epoxidase. Don't go into details. Now, another topical broad spectrum antifungal, or main one we need to talk about, is amorolfine, which is also fungicidal. It inhibits sterol biosynthesis in the fungal cell membrane, leading to membrane disruption and fungal cell death. Now, amorolfine, as you can see, it looks like nail polish, so it is indicated for onychomycosis. So the fungal infection of the fingernails, toenails, and it's applied directly on the nails. You don't really need to go into details of the mechanism of action again. Just remember it affects the sterol synthesis in the membrane, and it's applied as nail polish. Okay, so it's topical for onychomycosis. Now, ectoparasites. Ectoparasites are basically, as you can see here, we have lice and we also have scabies. So those are, organisms that will attack the body either on the hair, on the skin, between the digits, and so on. So we need to give an agent that will attack this specific organism. So either the lice or the scabies. So mainly we're trying to attack the nervous system. But we do not want to attack the human cells. So we need something very specific. Let's start with lice. What is happening in lice? So it is caused by pediculous species affecting the scalp, body, and pubic regions. It causes significant pruritus and it feeds on the human blood and so on. So in the head, it's a pediculus capitis. In the body, it's pediculus corporis, and the pubic area, it's pediculus pubis. Scabies, on the other hand, is a highly contagious condition caused by the mite Sarcoptes scabiei, which burrows through the epidermis and lays eggs. So usually, the typical patients would present, for example, intense pruritus, and they have like dots or lines in between their digits, and they have intense itching, especially at night, and other family members would be affected because it's very contagious. So they'd say, okay, my son came in he has very severe itching, and actually his sister started having itching this morning too. So you start thinking about scabies. So because of the intense itching, there will be excoriations and disruption of the skin, and this can allow other infections to start attacking the body. So they can be secondary infections with bacteria because of the scabies. So all household members need to be treated. Even if one patient presents, it's very contagious. You need to treat the whole family and you need to wash the garments in bed and everything. So I have five medications to talk about here: the permethrin, lindane, lindyl benzoate, crotamidone, and ivermectin. Permethrin is the gold standard. It's very effective, and if you get a question, it's most likely permethrin. Gold standard for both scabies and pediculosis. It's very effective, excellent safety profile. It's a neurotoxin affecting arthropod neuronal membranes. Again, we said we are trying to attack the nervous system. What permethrin does is it prolongs the sodium channel activation. So now the sodium channels are still active. They will still allow the sodium to pass, and this will keep exciting the nervous system of the either scabies or pediculous species. And now they have neurotoxicity and then they die. But they do not affect the mammalian cells. So low mammalian toxicity because it has poor dermal absorption and rapid metabolism in mammals. But it affects arthropods. And the way I remember the mechanism of action is permethrin will permit sodium. Okay, permethrin permits sodium activation, so it prolongs sodium channel activation, and it's applied as a cream from head to toe. Now in lindane, lindane is absorbed directly through the parasite's exoskeleton and their ova. It acts by blocking GABA-gated chloride channels. So again, it will cause hyperexcitation of the nervous system, but through a different pathway. Now, instead of keeping the sodium channels open, we are blocking the GABA-gated chloride channels. GABA usually inhibits the nervous system. So if you block GABA, you're removing the inhibition. So now there's more excitation of the nervous system. Now, cure rates are inferior to permethrin for both lice and for scabies, which is why permethrin is the gold standard. And large quantities can cause neurotoxicity in humans, which manifests as the patient will have headache, dizziness, seizures. So you need to use with caution. Oh yeah, this is how I remember lindane too. My mouse is acting up again. So I'm imagining a woman called Linda, and she likes shopping here. So GABA, Linda. So lindane GABA. Benzyl benzoate. So it's again both for scabies and pediculous species. It is effective, economical, cheap, and everything. It's applied to the entire body, and adverse effect is skin irritation. This is less high yield compared to the other drugs, so nothing much you need to remember about this, except that it's also used for ectoparasites. Cretamidone. Again, for scabies, but it's also for pruritus. So severe itching, you can also use cromatitone, crotamidone. So symptomatic relief during treatment. So for example, if the patient has any pruritus for any other cause, you can also use crotamidone. So again, to remember this, I'm imagining a person who's holding a crouton and they're just rubbing themselves with it. So itching, crotamidone. Apply to the whole body 2 to 3 times with 24-hour intervals. Again, you need to know in such details. Skin irritation. Now, imagining itching, cotameton, skin irritation. Ivermectin. Ivermectin is an anti-hemolytic drug. You probably remember this from POD, I hope. Um, so this is used for helmets. Thus, it's also used for scabies and lice, and it's the only systemic option. So others, as we mentioned, are topical. Antihelminthic, which is ivermectin, is oral. So it has high affinity to glutamate-gated chloride channels. So it enhances chloride conductance and hyperpolarizes the cells. So this will cause inhibition in the muscles. Now, we said permethrin would increase sodium conductance, neuroexcitation, hyperexcitation. Lindane would block the GABA chloride channels. Now we have also excitation. Here we are binding to the glutamate chloride channels. This will enhance chloride conductance. It will paralyze the muscle, inhibit the muscles, and it will cause paralysis. تمام? You see the difference between them? Again, low mammalian toxicity and poor blood-brain barrier penetration. So it's very selective for the alpha quad. 2 questions, and the lecture. Female patient was prescribed azole as treatment. Which of the following is adverse effective concern of this group of drugs? Remember, we said ketoconazole patient in a keto diet. Now they have liver failure or liver damage, hepatotoxicity. Next question. 5-month-old child is brought by the mother with itch, especially at night. What is the best management? We said gold standard, permethrin from head to toe. Now, our last lecture for today. Acne, psoriasis, and pruritus. Inshallah, quick lecture. I hope you guys are not tired. طيب, what determines the response to the drug? So a quick overview before we start, because we need to cover everything Dr. Devi covered. You never know where the question is going to come from. So what determines the response is, for example, a regional variation. So some areas in the body are more permeable, or they allow the drug to be absorbed easier, higher bioavailability, and so on. So you may need less quantities in certain areas of the body. Concentration gradients. So if you increase the gradients, there will be increased diffusion, pure physics. So you give higher quantities. Dosing schedule. So it depends on how you give the doses of the drug. So it can accumulate in the body, and that depends on the half-life of the drug. So if the drug has a long half-life, it will stay longer in the body, and you need to dose it. You need to give less doses for that drug. Vehicles, excipients, which is basically something that is carrying the drug, but it has no effect on the drug itself. It just, for example, if it's oil-based, it will act as a moisturizer, or if it just helps carry the drug, but it does not have effect on the condition itself. And finally, occlusion. So if you have a dressing that would keep the drug in close contact with the skin. So this will increase the drug penetration. General knowledge, nothing much to say about this, honestly. Starting with acne. So acne is a skin condition that occurs when hair follicles are plugged with oil in dead skin. So it can start as just clogged pores, and then those clogged pores can have bacterial infections. Bacteria will start to proliferate, and now this will cause like infections, pus formation, blackheads, pustules, and so many different effects in the long run. But basically, this could be a problem with sebum production, which is oil production, or desquamation, or the removal of the dead keratin cells, and so on, or bacterial proliferation and inflammation itself. So here we have different examples. We have the whiteheads, which are plugged pores, blackheads, which are open plugged pores, papules, cysts, which are painful and pus-filled. You have nodular acne, which is large, solid, painful lumps, and pustules, which are basically filled with pus. Now, pre-treatment assessment to determine. So you need to assess the patient before starting the treatment. to check what type and the severity of acne, because we have different managements for different severity of acne. So you can either give retinoids, you can give antibiotics, topical, oral antibiotics, and so on. Skin type, if the skin is dry or oily, and therapies target more one or more key factors. So as we said, it could either be a problem with oil production, with bacterial proliferation, desquamation of the skin, and so on. So we have three main groups. We have vitamin A derivatives, which are the retinoids, tretinoin, isotretinoin, very popular. I'm assuming you guys heard about them. Antibiotics, we have clindamycin, erythromycin, and sodium sulfacetamide, and miscellaneous like benzyl peroxide. Let's start with retinoic acid, which is tretinoin. So, mechanism of action of tretinoin is it binds to cytoplasmic receptors within the keratinocyte. So, what happens is it will activate specific regulatory DNA sequence. So, it will stimulate transcription of drugs. Bunch of words. What is happening? Let's look at this. So, here you have the retinoic acid, tretinoin, binding to the receptor. Now, then this receptor will go to the nucleus. It will activate the transcription of the retinoic acid responsive genes, and those will affect specific receptors, which is the RAR, retinoic acid receptor. So it will affect RAR, and what are the effects is it will increase the proliferation and differentiation of cells. It will increase epithelial turnover, so it will tell the old cells to get out with the bacteria and with everything. It will increase the shedding of the old skin and decrease the formation of comedones. تمام? So it will stimulate the transcription of target genes, which is for the RAR. Now, the effect is decreased cohesion between epidermal cells, increased epidermal cell turnover, as we said, and it will cause expulsion of the open comedones and rupture of the closed ones, and reduced follicular occlusion, as we saw in the other slide. So it's usually topical for both non-inflammatory and inflammatory acne, and you need to continue therapy for a long time in order to see clinical results. And you guys probably heard about isotretinoin and tretinoin, so you probably know the adverse effects. Main adverse effect, edema and dryness. This is why they tell patients who take isotretinoin to keep moisturizing, Vaseline, eye drops, everything. It causes severe dryness. May increase tumorigenic risk of ultraviolet light. So avoid sun exposure or use sunblock because it can increase the risk of tumor. Teratogenic. Precaution should be taken even if the patient is taking topical tretinoin. Very teratogenic, cannot be used with pregnant patients, so you need to do a pregnancy test, check the patient is not pregnant. Keep her on contraception because she cannot get pregnant while she is taking tretinoin, topical or oral. Next, we have isotretinoin. What is different? What's the difference between tretinoin and isotretinoin? So it's used orally. As we said, the other one is topical, this one is oral. And when do we use oral? We said if we have severe extensive disease. So here we have severe cystic or nodular or inflammatory acne, unresponsive to other drugs. Now we need something oral, we need something systemic, which is isotretinoin. Daily dosing can be used as monotherapy, but before starting therapy, you need to check the liver function, lipid profile. If you've ever taken isotretinoin, if you know someone who takes it, you know that they need to check their cholesterol levels, lipid profile, liver function test, all those before starting therapy, and keep testing them every once in a while. Again, dryness and itchiness of the skin, teratogenicity, so you need to keep them on contraceptive for at least 1 month before, throughout therapy, and 1 menstrual cycle following discontinuous days. You should not keep any chance. There is a baby in here. Antibiotics. Now, we have erythromycin, clindamycin, tetracycline, and doxycycline. Those are the main ones that are used in acne. Most are effective against P. acnes. You use topical for mild to moderate, systemic for moderate to severe. As we mentioned previously, topical is good for mild to moderate. Otherwise, you need something oral. Adverse effects, they depend on the antibiotic we're using. We're not going to go through a mechanism of action for the millionth time. I guess you guys are bored of them. But important side effects we have for erythromycin, it causes GI effects, QT prolongation, it can inhibit CYP3A4 enzymes and cause hepatotoxicity. Clindamycin, remember we said the main thing we need to think about is the C. diff infection, which causes pseudomembranous colitis. Tetracycline that causes teeth and bone effects, so it causes staining, which is why we don't give it to kids, and it causes photosensitivity and hepatotoxicity. Now we have benzoyl peroxide, which is the miscellaneous one. What happens is benzoyl peroxide will penetrate the stratum corneum, penetrate the epithelium and the follicles, and it goes inside, as you can see in this picture. So it will be converted to benzoic acid in the epidermis and the dermis, and as you can see in the picture here, it will cause the pore to unclog, so it's comedolitic and decrease the inflammation and oil production. So it's effective against P. acnes and comedolitic and healing effect. Adverse effects include contact sensitization in very few patients. You need to avoid contact with eyes and mucous membranes, and it can cause bleaching of hair and fabrics. All you need to remember is it goes inside the skin, penetrates the cornea, and has comedolitic and healing effects. For psoriasis, again, general overview. It's a chronic autoimmune disease. It causes patches, which are called plaques, can even affect the nails, the tendons, and so on. Again, we are treating to control the disease rather than cure the disease. So topical for mild to moderate cases, again, systemic for moderate to severe cases. Medications include corticosteroids, tazarotene, acitretin, calciprotein, methotrexate, and other biologic agents. You really do not need to know the mechanism of action in detail. So we're just going to talk in general. Corticosteroids, we talked about them in literally every single disease so far. So just remember it's anti-inflammatory, anti-proliferative. You can use hydrocortisone for the face and intertriginous areas. Thick plaques, you can use ones with stronger efficacy, like betamethasone, clobetasol. Stronger ones for the thick plaques. Again, potent treatment should be limited to 2 to 4 weeks because we saw the severe adverse effects with glucocorticoid use. So short time and taper. Adverse effects including atrophy, telangiectasia, and striae. We discussed all the effects of glucocorticoids before. Tazarotene, it's a retinoid which is converted to tazarotenic acid. No need to know the mechanism of action. I highly doubt they're going to ask about such a weird stuff. But you need to remember it is teratogenic again. Tazarotene, teratogenic. Again, make sure the patient is not pregnant and give contraceptives. Adverse effects, peeling, erythema, photosensitivity. So this irritation can be reduced by adding corticosteroids. طولي بس يعني في sake of completion. Acitretin. It's a retinoid useful for severe psoriasis. It's given orally. So adverse effects include cheilitis, which is inflammation of the lips. You have alopecia, hair loss, hypertriglyceridemia, and hepatotoxicity. This is the worst teratogenic. So you cannot have the patient be pregnant. Give contraceptive. Make sure you do a pregnancy test before. You can't even donate blood with acitretin. So blood donations are contraindicated for 3 years after discontinuing the pills. It will stay in the blood, stay for a long time. You cannot even donate blood. And make sure the patient is not pregnant again. So far, the only drug we talked about that was safe in pregnancy was sulfasalazine. Other drugs are sus, and then anything with a highlighted teratogenic word, category X, you cannot give in pregnancy. And this one, acitretin, even in the blood donation, is contraindicated. Now, consumption of alcohol will cause metabolite buildup, which will also stay for years. As we said, this contraindicated. You cannot give blood for 3 years because it stays for a very long time. Calcipotriene is a vitamin D analog. Again, you can remember it by calcium, calci, and vitamin D are related to each other, so it's a vitamin D analog. So it's for plaque type psoriasis. Adverse effects, again, burning, itching, edema, low yield. Methotrexate, we discussed methotrexate. It's a folic acid antagonist, inhibits dihydrofolate reductase, so less tetrahydrofolate. It's usually reserved for severe disabling psoriasis. Contraindicated in pregnancy, we said it's category X. In nursing mothers can go through the milk. Patients with alcoholism, we said it affects the liver. Adverse effects, hepatotoxicity, leukopenia. Remember the methylmnemonic we had? Other, we have biologic agents, etanercept, adalimumab, subhanAllah, they keep coming up everywhere. We have the same drugs for all autoimmune diseases. So anything affecting the immune process in the body, TNF inhibitors, methotrexate, corticosteroids, anything affecting the immune disease is going to come up with every autoimmune disease. Immune process, I mean. Most recent one, we said secukinumab, anti-IL-17 monoclonal antibody. Again, MAB, monoclonal antibody. A recent one, not very first line or second line حتى. Pruritus is our last thing for today. Alhamdulillah, we're almost there. Almost there. Pruritus is basically itching. Just itching. تمام؟ بدون هالفلسفة كلها. So it can be due to allergies, contact dermatitis, dry skin, fungal, lice, psoriasis, different causes. But it's basically just itching. Mediated by different compounds, we have histamines, prostaglandins, leukotrienes, serotonin, acetylcholine substance P. You really do not need to know how they cause pruritus. Just know that you have several mediators affecting pruritus. So we need to inhibit those mediators or block any chemicals, because we said any you can be allergic to any chemicals and irritants, so you need to block those or inhibit the mediators or treat the disease that's causing it. So we said we can have chronic kidney disease or sickle cell or anything causing pruritus, so you can cure the disease to cure pruritus. So it depends on the underlying factor. Main thing for pruritus is antihistamine. I'm sure all of us had itching or allergies at some point and you took antihistamines. So it's a H1 antagonist, reversible competitive H1 antagonist. First line for generalized pruritus, also used for urticaria, which is basically when you have weeds. Now, first generation, second generation. What is the difference between them? First generation, you have diphenhydramine, dimenhydrinate, chlorpheniramine, doxylamine. So usually ending with ene or ate. Those are the first generation. Second generation, usually adene ending. Loratadine, phenoxyphenadine, desloratadine. Only cetirizine is a second generation that does not end with adene. So just remember those. What is the difference between them? Main thing you need to remember is that first generation is sedative. It penetrates the CNS, so it can cause sedation. Second generation, the adene ones are non-sedating. So adene, non-sedating, so the patient stays awake. Again, they have less sedating because they have less penetration to the CNS. First one, sedation, antimuscarinic action, and anti-alpha adrenergic action. So first generation, when do you think they'd be helpful? So they cause sedation and they decrease pruritus. So the patient who has night exacerbation, so they have itching and it's worse at night and it's preventing them from sleeping, you can two birds, one stone. So you give first generation antihistamine, attack the pruritus and help with sleeping. Second generation, non-sedating. Adene, non-sedating. So indications, again, we said allergic reactions, allergic conditions, for motion sickness too, and for insomnia. So as we said, if the patient cannot sleep, you can give them the sedating or sedating one. And then also used for motion sickness because it can affect in the vestibular system too. We also have anti-muscarinic effects, as we discussed in the Myasthenia gravis lecture. Those are the same effects. Now we also have doxepine. Doxepine is an antihistamine that blocks both H1 and H2, and it's also related to tricyclic antidepressants. TCAs also have one major side effect we need to know. Whenever you're studying neuro, I guess you guys still don't take neuro, but anyway, tricyclic antidepressants have a major side effect, which is anticholinergic activity. So you need to avoid using doxepine, which is related to tricyclic antidepressants, in patients who can be affected by this anticholinergic effects. So who are those patients? Those patients are the patients with narrow angle glaucoma, because basically anticholinergic effect, it can cause dilation of the eyes. So when the eye is dilated, you are closing the angle between in the lens and the cornea. When you're closing the angle, this will cause buildup of pressure in the eye, and this will cause glaucoma in the patient. So you need to avoid doxepine and TCAs in patients with narrow angle glaucoma or tendency for urinary retention, because anticholinergic effect also includes closing the sphincters. So this will cause buildup of urine and cause urinary retention. So for example, if patients have BPH, they are more prone to having urinary retention. So you need to avoid doxyphene in such patients, and also taking MAO inhibitors, monoamide oxidase inhibitors, because both together, when you give TCAs with MAO inhibitors, you'll understand this more when you take neuro. But both together, they will cause serotonin syndrome, hypertensive crisis, and effects we do not really want. We're done. Two questions for the last lectures. For the last lecture, the 23-year-old female developed a rash on her face, chest, and upper back. She was concerned about it. She came to seek help. Doctor prescribed this described this as acne and prescribed her, sorry for the typo, isotretinoin. Which of the following tests should be done by the doctor before prescribing this drug? Most important thing, pregnancy test. She cannot be pregnant. Yeah? Most important thing. And you give her contraceptives, كمان. Why is clindamycin given with benzoyl peroxide? This was in one of the previous launch papers, and it's important. So let's discuss this. Okay. To reduce occurrence of antibiotic resistance. What exactly is happening here? So benzoyl peroxide's mechanism of action is based on generating highly reactive free oxygen radicals. So bacteria, whenever they get resistance to any drug, it's basically, for example, let's say if a bacteria is resistant to penicillins, it's basically because they developed an enzyme or something that will counteract the effects of the drug. In benzoyl peroxide, the bacteria, which is in acne, they cannot develop resistance to this oxidative mechanism. So when you give clindamycin and benzoyl peroxide together, benzoyl peroxide will kill any cells that developed resistance to clindamycin. So you are suppressing the emergence and selection of resistant bacterial strains. Basically, what you're doing is you're killing the resistant cells, so now clindamycin can do its work. So you give them together to reduce occurrence of antibiotic resistance. This brings us to the end of today's crash course. I am so sorry this was long, but hopefully this was beneficial, and you guys got a good overview of all the important stuff in MSI Pharma. Best of luck يا رب الله يوفقكم وإن شاء الله this is going to be an easy exam. Don't worry about pharma lectures. Honestly, clinical and patho is more high yield, so you need to focus on those, but do not ignore the pharma because they can get very specific questions about the side effects and the annoying stuff, mechanisms, not very clear questions. So it's really important to understand pharma well, not just memorize. And you guys got this, inshallah. Please scan the QR code at the end of the presentation. And best of luck. If you ever need any help or have any question, you feel free to contact me using my email or phone number at the end or the beginning of the presentation. ويعطيكم العافية إن شاء الله. السلام عليكم.